Hi, Selby, can you please start recording?
You may begin.
Thank you. Good morning, everyone. The meeting of the Interdepartmental Serious Mental Illness Coordinating Committee, also known as the ISMIC, is now called to order. We will now conduct a roll call of the committee members to ensure that we have a quorum before we begin. We will start with federal membership in the order outlined in the charter. The federal member or designee representing the agency should state their name and respond here when the agency is called. The Secretary of Department of Health and Human Services.
Good morning, everyone. This is Meena Vaidlingam from HHS.
Joel Dubinitz from ASPE.
Thank you. The Assistant Secretary for Mental Health and Substance Use.
Miriam Delphin-Rittman.
The Attorney General.
Maria Lifshitz here.
The Secretary of Department of Veterans Affairs.
Sandy Resnick here.
The Secretary of Department of Defense. The Secretary of Department of Housing and Urban Development.
Corey Minor Smith.
The Secretary of Education.
Megan Whitaker here.
The Secretary of the Department of Labor.
Jennifer Sheehy here, Deputy Assistant Secretary for ODEP, and for Assistant Secretary Taryn Williams. Thank you.
The Administrator of the Centers for Medicare and Medicaid Services.
Kirsten Baronio here representing CMS.
The Administrator of the Administration for Community Living.
Andrea Callow here.
Sean Terrell.
And the Commissioner of the Social Security Administration.
Hi, this is Taffy McCoy for SSA.
Thank you. Now we will conduct a roll call of the non-federal public members going in alphabetical order. Please respond here when your name is called. Trinidad de Jesus Arguello. Ron Bruno.
Here.
David Covington.
Here.
Brian Hepburn.
Here.
Jennifer Higgins.
Here.
Stephen Leifman.
Here.
Amanda Lip.
Here.
Ajoa Smalls-Manty.
Here.
Sue Smith.
Here.
Wynala Sprague.
Here.
Rethelio Stroud. Here. R. Telos St. Amar.
Present.
Sarah Venson.
Here.
Catherine Warburton.
Here.
And Anitra Warrior.
Here.
Thank you. We have a quorum. As a reminder, today's meeting is being live streamed. Please place electronic devices on silent mode. Virtual speakers are reminded to please state your name at the start of your comments so that the transcriptionist and writer can capture the information. Just a quick note that photographers will be taking pictures throughout today's event. We've included a disclaimer on this slide as a reminder to all attendees that this is a public meeting and participants may be photographed or recorded. I will now turn the meeting over to the Interdepartmental Serious Mental Illness Coordinating Committee Chair, Dr. Miriam Delphin-Rittman.
Thank you so much, Pam, and good morning, everyone. It is just such a pleasure to be able to be together again. For those who are here in person, welcome to SAMHSA. So good to be able to see you in person. And for those that are joining us online, thank you so much for your time and being with us today as well. You know, we are just so grateful for everyone's service on this committee. We know that everyone is busy, and so we're grateful for the gift of your time and your service to these really important discussions and conversations we'll be having over the course of today. We've got a packed, full agenda, so really looking forward to diving in. I'm going to go ahead and turn the agenda over to Pam real quick, who's going to take us through the minutes, and then I'll do a brief sort of update, sort of some things happening around SAMHSA since we last met. We've been in the zone. and in partnership, actually, in fact, with many of you. So really looking forward to providing an update. Pam?
Thank you, Dr. Delphin Rittman. So everyone should have received a copy of the March 27th, 2024 meeting minutes from me for review. Does anyone have any comments or questions on the meeting minutes? We will entertain a motion to accept these minutes. May I have a motion to accept the minutes?
So moved.
Thank you, Judge Liefman. May I have a second motion to accept the minutes?
Second, Corey Minor Smith.
Thank you, Corey. Would all the ISMIC members unmute themselves? All in favor, say aye. All opposed, say nay.
Aye.
Aye.
Thank you. The minutes are accepted. I will now turn the agenda over to Dr. Delphin Rittman.
Thank you so much. So again, welcome everyone to the second meeting this year of the ISMIC. I again want to just extend my gratitude to everyone for being here. We also have some new members. Actually, am I doing that yet? Actually, no, we're going to start with introductions. And what I would like for everyone to do is share your name and then say one word that comes to mind when you think of ISMIC. And so I'll start, Miriam Delphin Rittman, and the word that comes to mind for me is collaboration. Okay.
So I'm Anita Everett. I'm the director for the Center for Mental Health Services here at SAMHSA, and I'm going to say accomplishments.
I'm Sarah Vinson. I'm the chair of psychiatry at Morehouse School of Medicine, and my word would be hope.
Great minds think alike.
My name is Steve Leifman. I'm a judge in Miami-Dade County, Florida, and I really was going to say hope.
Hello, I'm Audra Smalls-Monte. I'm an emergency psychiatrist in New York City, and my word is recovery.
Jennifer Higgins, ISMIC member from Western Massachusetts, and my word is opportunity.
Ron Bruno, and my word would be passion.
Good morning, David Covington, and collaboration.
Sue Smith, hope.
Do you want to jump in, Sue? Hope. Oh, hope again. Okay.
Sure. Joel Fuentes, my word is coordination.
Belina Shaw, senior medical advisor, and I would say together.
Hi, I'm Pamela Foote. I'm the DFO for the ISMIC. My word was going to be hope as well.
Andrea Callow, I would say recovery as well.
Arc Telos Saint Amor, mandatory pronouns are they, them, their, and my word is critical.
Brooke Dimbert, policy advisor with the Bureau of Justice Assistance, and my word is important.
Marissa Farina Morse. I'm an associate deputy director at the Bureau of Justice Assistance, leading the Justice and Behavioral Health team, and my word is motivation.
Hi, I'm Joel Dubinitz from the Office of the Assistant Secretary for Planning and Evaluation at HHS. And I am just going to go with collaborative along that theme.
I'm Doug Slaughter from SAMHSA. Doug Slaughter from SAMHSA, Work Group 3 co-steward, and my word would be cooperative.
Sandy Resnick from the VA, and I'll use community.
Rothelia Stroud, ISMIC, and I'm going to put challenge behind coordination and collaboration.
Brooke Mount with the Bureau of Justice Assistance, and I will say transformative.
Yeah, and let's go around the room as well.
My name's Karen Gentile, and I'm the in Center for Mental Health Services, the director of the Office of Technical Assistance and Coordination, and my word would be connection.
Hi, I'm David DeForney. I'm the director of the Division of Community Behavioral Health in the Center for Mental Health Services at SAMHSA. I'm also the co-steward for the financing of subcommittee, and my word will be potential.
Hi, Kirsten Painter with Neidler, and my word would be yes, because I've been around since the beginning of ISMIC, and it's a yes. No.
Hi, I'm David Barry. I'm with SAMHSA. I'm the Division Director for the Suicide Prevention and Community Supports Division. And I'm also the co-steward, one of the co-steward leads for the Access Work Group.
Good morning, I'm Tara Andrews. I'm the Special Assistant for the Center for Mental Health Services at SAMHSA, and I'm also a co-steward for the Access and Engagement Work Group.
Good morning, I'm Susan Marsiglia Gray. I'm the Director of the Division of State and Community Systems Development at CMHS.
Hi, my name is Jamie Pittman. I'm an APA AAAS Fellow with SAMHSA.
I know we forgot the words. I feel I know it's been said a lot, but I think collaboration is my word.
I just got here, but also collaboration seems accurate for me.
No.
I think opportunity.
Try to get away without having to do it.
Oh, no, we need
I'll
the
say
words.
progress.
All right, progress, yes. Online?
Yes, we can do that.
Yeah, so why don't we go to online now, and we'll just go according to the order on the screen. So we'll start with Marielle.
Advancement.
Okay, can you do, and can you let us know sort of where you're from, name, the
Sorry about that. Hi, everyone.
okay.
My name is Marielle Lifshitz. I'm a senior advisor in the Office of the Assistant Attorney General and the Office of Justice Programs at the Department of Justice. And my word would be advancement.
Great, thank you. Next we see Winnie. I'm just gonna do first names. Just Winnie, we'll just book along.
Yes, my name is Winnie Sprague and I'm from Northeast Ohio. I'm the medical director at Children's Advantage, and my word is supportive.
Great, thank you. Tom?
Good morning, everyone. My name is Tom Codere. I'm the Principal Deputy Assistant Secretary here at SAMHSA. And my word was going to be recovery, but somebody used it already, so I'll say possibility.
Awesome. Brian?
Hi, thank you. Hope everyone is having a good day. My name is Brian Hepburn. I'm with NASHBID, and my word is champions.
Awesome. Greg?
Good morning, Public Health Advisor with SAMHSA. I'm one of the co-stewards for the Criminal Justice Working Group, and my word is impact.
Nice. Catherine?
Good morning from California, very early morning, California. I'm the medical director for our state hospital system, Kate Warburton, and I'm going to go with hope.
Fantastic. And Anitra?
Good morning, everyone. My name is Anitra Warrior. I'm a psychologist based out of Nebraska, and my word is connection.
Fantastic. Mina?
Good morning, everyone. Meena Vaidalingam from the Office of the Assistant Secretary for Health. My word is caring.
Fantastic. Sue? Okay, Sue said, yep. Jennifer?
Good morning. I'm Jennifer Sheehy with the Office of Disability Employment Policy, and my word is advocacy.
Nice. Marion? Marion McCoy?
Oh, I'm sorry. This
That's okay.
Taffy. I'm a social science analyst at SSA, do a lot of mental health research, and my word would be promise.
Thank you. Sean?
Sean Terrell, Administration for Community Living. My word would be self-determination.
Thank you. Kirsten?
Hi, Kirsten Baronio. I'm a senior advisor in the Office of the Center Director at the Center for Medicaid and CHIP Services at CMS, and my word is awareness.
Thank you. Megan?
Good morning, Megan Whitaker. I'm a policy advisor in the Department of Education's Office for Special Education and Rehabilitative Services. My word would be commitment.
Great. Corey?
Good morning, Corey Minor Smith, Senior Counsel for the Department of Housing and Urban Development, and my word is driven.
Thank you. Richard?
Good morning. I'm Richard Davis. I'm a senior policy advisor at the Office of Disability Employment Policy, where I lead the Aspire and Neon initiatives. And my word would be transformation. Thank you.
Thank you. Michael?
Hi, my name's Mike Watterson. I work at SAMHSA with the CCBHC program, and my word would be partnership.
Thank you. Nancy?
Hi, my name is Nancy Kelly. I'm the Director of the Division for Children in School Mental Health and at SAMHSA, and my word would be innovation. Thank you.
Great, thank you. Margaret?
Hi, I'm Peggy or Margaret O'Brien. I'm in the Center for Behavioral Health Statistics and Quality at SAMHSA and the Department or the Office of Evaluation. My word would be partnership.
Thank you. Amanda? Okay.
Hello, good morning, everyone. My word would be thoughtfulness.
Great, thank you. And Jacob?
Good morning, Jacob Ackerman, Senior Policy Advisor in CMS, the SIO, and my word is cooperation.
Thank you. Let me see. Maia?
Good morning, everyone. So I'm Maia Banks, Supervisory Public Health Advisor here in Sampson and CMHS OD, and my word is vision.
Thank you. And I think, let me see, we did Amanda. Pam, did you did, yeah. Nima? Oh, yeah,
Good
yeah.
morning, Nima Sheth, Senior Medical Advisor in CMHS. I'd say my word is data-driven.
Okay, great, thank you. Abdallah? Oh, your sound?
Yep, sorry. Hi, good
No,
morning,
no
everyone.
worries.
Abdallah Ibrahim here, CMHS CCBHC coordinator, and my word is perseverance.
Fantastic, thank you. And I think that's, yeah, I think that's everyone. Well, thank you so much, everyone. It's interesting, the themes and certainly collaboration, perseverance. I think a lot of words that sort of reflect really where we are with the moment and the really important collaborative visionary work that's happening. And so really appreciate everyone's, again, service to the ISMIC and partnership as well. So we're going to go ahead and dive right in. You know, for those wondering, next slide. For those wondering sort of what's happening at SAMHSA, there's been quite a bit. And so I'll go through a number of different updates. But before I do that, next slide. Before I do that, I want to do a special welcome. We have our newest ISMIC member. We're always excited to expand the ISMIC team. So want to say welcome to Dr. Ajoa Smalls-Mantley. Dr. Smalls-Mantley is a physician scientist, writer, medical media consultant, organizational leader. She earned her medical degree from Columbia University, Vigolos College of Physicians and Surgeons, and completed her psychiatry residency at Mount Sinai Hospital, where she served as chief resident and president of the Graduate Medical Education Council. Afterwards, she completed her psychiatry fellowship at Columbia, working on mental health policy in New York. And we are just so glad to have Dr. Smalls-Mantley with us. And so welcome to the ISMIC. Yes, welcome to the ISMIC. And, you know, okay. And, you know, I'd like to also take a moment to honor the memory of and legacy of Adrian Lightfoot, who passed away on August 20th, 2024. Adrian had been an active, really long time, you know, member of ISMIC, longtime peer specialist and community advocate. We will miss her dearly. And so just wanted to just have a moment of silence for Adrian. Okay, thank you. Next slide. So again, some quick updates, you know, wanted to share some of the Recovery Month activity. It was an active month. So grateful for the Office of Recovery team and our many partners that helped to convene, attend, and really celebrate Recovery Month with us. Some of the activities we had included our Recovery Walk, which was exciting. We started at Federal Plaza and then walked down to the monument. Our team is growing there, so it was wonderful to see I think we had over 200 people come out, and so we're really pleased about that. We also had an online recovery gallery, and so certainly I hope you had a chance to check that out. It was wonderful. We received over 200 submissions of artwork, people sort of sending us their depictions and representations of recovery. And so that was wonderful to see those art submissions. And then on September 24th, we hosted our Trailblazers Award ceremony, and that was wonderful as well to be able to honor, true trailblazers in recovery, folks who are doing innovative work, meeting people where they are, truly embodying and helping to spread hope and the message and vision of recovery. So it was wonderful to be able to honor those individuals and family members and young people. And so that was a real exciting event as well. Next slide. Also wanted to talk about our 988 Day. And so we celebrated the first 988 Day on September 8th. And we had what we call the 988 wall highlights. And so many people posted different digital shareables or different ways that they were celebrating 988. And so with the hashtags, we were able to create a wonderful 988 wall that just shows all the different ways people were celebrating and honoring 988. The theme this year was No Judgment, Just Help. No Judgment, Just Help, and quite a bit of participation on that day. We had over about 152 million posts and impressions across different social media platforms, and about 4,600 posts. So quite a bit of excitement and energy related to that as well. Next slide. So we also, in terms of Suicide Prevention Month, we were happy to lead a number of different webinars. We unveiled the new suicide prevention webpage, so do take a look at that if you haven't seen that. Share it, help us get the word out about it. It has just a whole wealth of information related to suicide prevention. We released a blog, a number of different sort of media graphics, all geared towards sort of helping to raise awareness around suicide prevention. And of course, we have the 2024 National Strategy for Suicide Prevention, which we released as well. So a lot of activity that month as well. Next slide. And then, of course, as you know, suicide prevention is a key component of crisis services. We were so pleased to be able to celebrate the 2-year anniversary of 988. When we look at the metrics, certainly what we're seeing is that people do see 988 as a viable resource. As of July, there were over 10 million calls, texts, and chats that came in. And you'll see some of the metrics there in terms of increases in the various modalities. So about a 34% increase in calls, a 51% increase in texts. We did see chats go down, but we actually think it's perhaps because people are tending to use their phones now for like everything. The phone is the computer these days, and so I think that's certainly what was likely driving some of that data. Looking ahead, the thing that we're excited about now is geo-routing. So being able to have people connected to localized support and services. So now when someone calls 988, their call will ping off the local cell tower and then connect to the 988 call center that's closest to them. And that is really a big deal. It means that people are being connected now to localized support, which really does make a difference. So excited about that. And then we're also continuing to sort of evaluate. We have a formal evaluation going on related to 988. And so continuing to look at metrics, and it's so important for us to see like what's working. Where do we see areas where we might want to sort of dive in and do some additional work. And then in addition to that, a big focus is continuing to get the word out. We know now that the call centers have capacity, that backup centers have capacity. And so doing awareness campaigns, actually we're doing paid campaigns for the first time to help get the word out, focusing particularly on sort of under-resourced or at-risk groups that may be not using services where there may be a need. And so excited about that work as well. Next slide. That we were pleased to be able to release the National Strategy for Suicide Prevention earlier, several months ago as well. The wonderful thing about that is it also comes with a federal action plan. So take a look at the NSSP itself, but also take a look at the federal action plan. I think the federal action plan is important because it includes over 200 items that are being implemented across government. But I think the piece that's important there is I think it can give really good ideas too at the community level around potential areas to sort of focus and target interventions. So quite a bit of rich work. In terms of what the strategy includes, it was wonderful to be able to get ongoing input from people with lived experience. That was an ongoing part of the work. It has an important focus on equity. And so that certainly there's language and content related to that. There's content related to youth and social media. We know that in terms of the work, even through the Kids Online Health and Safety Task Force, that is such an important area for us to pay attention to. We see young people struggling with social media. Through our focus groups, they also let us know that, look, they have things coming in their news feeds that are troubling and want more assistance there. And so certainly take a look at some of the content there. And so next slide. Also wanted to talk about, as I mentioned, the Kids Online Health and Safety Task Force. We were able to put out a number of products. So one thing that we did was put out a report that has recommendations for family members, for industry, for school personnel. It includes things like some of the content and work that the Social Media Center of Excellence is incorporated as well. So things like a family media plan, we know that can be so important. Families working together to develop a plan around sort of social media usage within the home. And, this content related to sort of balancing screen time versus non-screen time from a family perspective. So definitely take a look at those resources. Yep. And so more on the Kids Online Health and Safety, we did sort of listening sessions in order to sort of put the report together, did listening sessions with young people. And this is where they really told us, look, it's so important not to throw the baby out with the bathwater, that yes, it is true that there are harms that they encounter and challenges that they encounter online, but that there's also benefits. That young people who are struggling socially are sometimes able to connect with other individuals who they can relate to or who they can connect to. So kids who may be at the margins or from groups who experience discrimination. And so they did say that it's important to sort of take a balanced approach. The other wonderful thing about the task force is it was truly a cross-government collaboration. It was co-chaired by the Department of Commerce, so Assistant Secretary Davison was my co-chair for the task force, and then we had really great participation across government as well. The report also includes, content related to body image. So the first section of it is a summary, really what we're seeing in the literature as it relates to kids' online health and safety, and then we go into the recommendations, and it includes things like, exposure to violent content, body image, the other areas that you see there on the slide, promoting the importance of promoting educational content, and what have you. Next slide. So our youth summit, was just fantastic. The energy, so we did this several months ago as well, and many thanks to Tay and Youth Move team for helping to sort of collaborate with us on that and help with the planning. The really cool thing about this conference or this summit was that the young people, they were in charge. Like they set the schedule, they ran the sessions. Interestingly, the Saturday schedule started at 9 and went to 10 p.m. I saw it. When I saw it, I thought, oh my God, is that a typo? But I realized it wasn't a typo. But they literally had it but it was great. It was great energy. And I think they were just as energized at 10 p.m. as they were at 9 a.m. And so they put forward just great recommendations around, what will help in terms of their overall mental health and wellness. And I would say one theme that throughout was that, nothing about us without us. We want to be at the table. It's so important that we're at the table. And also, we want and need safe spaces to talk about mental health, to share with each other, support each other. And so now we're working with the various teams from that summit. Each of them have a SAMHSA mentor, and we're going to work to try to implement the areas that they shared with us. So really exciting, energized work. So Tay, do you want to add anything real quick? I thought it was wonderful, but if you want to, because you were so integral and just so grateful for your participation. And
yeah, no, I appreciate that. I mean, I just want to echo what you've said. I think it's just really, again shows the power of youth, that they are fully capable of doing all of the things any other age group can do, and pulled it off. I just think with, really, really spectacular success.
Yes.
And as someone who spends the majority of my time on the road traveling, it was one of the better summits that I've been to this year. And it was entirely youth-led and driven. And I think, again, that really tells you something, right? They're not just doing something at the level of like, oh, it's cute, look at what youth do. Like, they're doing something truly that excels even beyond some of the things that I'm seeing in adult spaces. So
yeah, absolutely. Thank you. Thank you so much. Next slide. Yeah. So the other thing, we were really, really pleased to release our NSDA. I think we broke a record. It was way earlier than we have ever released the NSDA. And I think the important thing about it is we also really worked on presenting the data in a way that is more digestible and manageable. So it includes infographics. It includes, again, as we did last year, content on race and ethnicity. And then you'll see some of the data there. What we know is that we still have work to do, right? Our work is not done. And we do see in terms of, if I just take the adult piece, about 1 in 4 adults struggling with mental illness, about 1 in 18 with serious mental illness, and about 1 in 20 having serious thoughts of suicide. So again, it is a renewed sort of call to action whenever we see the NSDA and see some of the recent data trends. But do take a look at that. There is a QR code there. And then we'll be following up with subsequent reports that further look at other aspects of the data in disaggregated ways. Next slide. The other area we've really been working on, and this is something that many of our grantees and providers have been sharing, that the data collection process is challenging. So we are working on streamlining our GIPRA tool. We're looking to have bring the time down to complete it to like 30 minutes or less. And really looking to improve data quality, but reduce burden. And so ongoing area of work that's happening there. I'm so grateful for the office and center directors, really across SAMHSA. It has been just such an important initiative, and everyone's just dialed in on it. And soon, we'll be able to have content. I believe it goes out for public comment. I think one of the next slides we have the timeline, but eventually there'll be an opportunity to provide public comment as well. So looking forward to that. There's a whole working structure that's been put in place to be able to do that streaming of the GIPRA. Okay, yeah, and so you see that. That's a little bit more on the GIPRA. So, the client looking to have content related to social drivers of health, core recovery outcomes, client level goals, and then also an administrative form that gets at the other areas that you see there. So behavioral health history, behavioral health screenings, behavioral health diagnoses. So stay tuned. We're steeped in that, but excited it's continued to move along, and appreciate everyone's feedback and over the last couple of years on the importance of sort of looking at that. Next slide. We were really, really pleased recently to also release a behavioral health navigator tool. And so what this tool does, you can select a state and look at the different behavioral health disciplines and see what requirements are necessary within that state to be able to work within the state. And so really quite a bit, it's an interactive tool. And it lists sort of again, the behavioral health disciplines across the country and the different requirements by state. So excited about that. As we know, workforce is such a challenge, and we want to increase and make it easier for people to understand sort of what they need to do, sort of what the process is, or what the work is, what the training is for them to be able to receive, their degree in a particular state and then ultimately practice in a particular state. So definitely help us get the word out about that as well. Next slide. And then in terms of our SOAR and TOR grant, we were really, really happy to be able to extend the TOR from 2 years to 5 years. Tribal communities had been sharing with us that 2 years is just not enough time, that between hiring and the different challenges around implementation, they were really needing more time. So we did extend that out to 5 years. And in addition to that, we awarded more than, over 150 tribes were able to receive, tribal communities were able to receive TOR. And then same thing with SOAR. SOAR, we extended it from 2 to 3 years. In terms of some of the metrics, you see provided services to nearly 1.3 million people, provided recovery support services to 1.4 million. And the thing that I'm really encouraged by is, through the naloxone saturation work and the really creative work that's happening in the states around getting naloxone out far and wide, we've seen over 550 overdoses. So again, opportunities for people to find recovery, experience long-term recovery. So really appreciate the work that's happening at the state level there. Next slide. And these, we love our QR codes. You see, we put them on everything, but these are just some more QR codes for grants. Check out our 988 toolkit. It has like really great digital shareables related to 988. And then our evidence-based practice resource center has quite a bit of content as well. So thank you. And I'm going to go ahead and turn the floor over to Dr. Everett, who will share some additional updates. So, Anita?
Thank you, Assistant Secretary. And what I'm gonna do is drill just a little bit deeper into some of the activities that the Center for Mental Health Services has been working on that are a little bit more related to the SMI, the serious mental illness, SED, serious emotional disturbance domain. So let's see, can we have the slides, please? There we go. Yep. So this first slide, one of the original ISMIC recommendations had to do with strengthening CCBHC, Certified Community Behavioral Health Clinics. And this is a slide that just reminds us all that this has been a journey, which is also the case with ISMIC. I believe this is our 8th year for ISMIC. And so it's been a journey. And CCBHC is in a similar way, started with an act of Congress in 2014 and have progressed to the state where we are now. Next slide. Just a reminder, I like this slide. It demonstrates that there are 9 required services for the CCBHC program. So from my perspective, as a person who worked as a clinician for many years in settings like this, what that means when you're a person living with a mental illness and or in need of treatment and or a professional who works in one of these settings, you can, with ease, in a well executed CCBHC, refer patients to things that they need, like coordinated care, like intensive case management style programs, addiction-related programs, if that comes up along the course of interface, and many recovery support programs. So I really like the array of services, and that's really important when you consider the needs of the people that interface with these systems. Although CCBHCs are sometimes associated with SMI, SED spectrum, they actually are designed to serve the full range of anyone who comes at the front door or knocks at the front door in need of treatment. So next slide. CCBHCs are, if they're not in a neighborhood near you, they're coming to a neighborhood near you soon, we hope. We have somewhere in the neighborhood of 500 CCBHCs. One of the things that excites me so much about CCBHCs is it is a national model. For too long, as many of us who've worked in the system for years know, different states have made different decision points about what's important at a point in time. And so their state plan, they're often fueled by or funded by developments in the Medicaid space, has funded first one thing, then another. And the CCBHCs say, no, these mental illnesses basically are the same wherever they occur, and individuals should have the same right to the same types of services across our nation. I believe in sort of my study of the past that this is the first real shot we've had at building a national vision for what the model should or could look like for those individuals since the original Community Mental Health Center Services Act, which was passed by President Kennedy in 1963. So 60 some odd years ago. I believe this is a national shot, and we're very, very proud of all the advances that we've accomplished with regards to CCBHCs. I consider that to be a game changer. The second game changer, Dr. Delphin-Rittman has talked a little bit about already, but crisis funding. Why I want to talk about that a little bit now is to focus on some of the assets that we in the Center for Mental Health Services also provide, which has supported the development of the crisis services system. So we do have the 988 number, as she mentioned, it's been in operation now for 2 years, but there are other parts to the system as well. And so what we like to think of, or still we use as a framing concept, which actually has some of its origins in some of our early ISMIC meetings, is starting with the person at the core of the system. What does a person in crisis need? They would need, in our vision, one of 3 things: someone to talk with, which oftentimes resolves situations, but not always. And if that's not sufficient to resolve the situation at hand, a mobile crisis team. And if that's not sufficient or doesn't resolve the situation at hand, crisis receiving facilities. We know from experience with our grants, which I'll talk just a little bit about later, our mobile crisis team grants, that nearly 75% of situations can be addressed in the situation where they occur, and which means we avoid referral onto an emergency department or inpatient care or other higher levels of care when they can be addressed in a situation at hand. So our block grant now for the last several years has a set aside which requires states to spend 5% of the amount of money that they are granted through the block grant. There we have CCBHC expansion grants, which also support. Okay, we're good. All right. We have CCBHC expansion grants, which also support the crisis enterprise because they require crisis services as a component, as one of those 9 required clinical components. The 988 office itself, which has become a real powerhouse in the ranks of SAMHSA, has a whole series of grants that it provides that support more skewed toward the end of the telephone or the answering. It's telephone, but it's also text and chat. And then we have our community crisis response partnership program, which is also our mobile crisis team. The next slide demonstrates a little bit about how states are funding various aspects of the crisis services. This is information from 2023, and it's information from a report that we generate now. Our plan is to do this annually, but this is the second one of these reports that we've generated. It's a survey basically of states that's given, and it indicates a little bit of where the states are using funds to fund the various aspects of the crisis delivery. So you see, of the states that reported in this survey, we sent the survey out to all of the states and territories. We got not 100% reply rates, but you see that 48 states, for instance, to use that first set of graphs there in the green, have used their mental health block grant in part to fund the crisis call line. And then you see the other various aspects of that with the green. Oh, no, sorry, the green is other SAMHSA fund. The blue is the mental health block grant that funds that are used that way. So you'll have copies of these slides if you want to study them a little bit more, but what it depicts is that states are using a variety of different sources. And how we also interpret that is that they are taking the crisis buildup of the system very, very seriously as a statewide initiative. Next slide demonstrates a little bit of future planning. We asked the states again in 2023 what they plan to develop in the next year. And so you see here, what I particularly like about this slide is the children's mental health. Although it's small, what we learned is that states collectively, the ones that responded, have plans to build out or add in 27 new children's mobile crisis teams. That would be teams that are specialized to respond to children situations as they come up in the community, and 23 children's crisis receiving centers. Those are planned on the horizon. And we have something nationally from this same report, something like 1,800 mobile crisis teams that have developed just in the last couple of years. So it is a growing system, and we really do think of that as one of 2 game changers in the mental health space, the CCBHCs being one and the 988 and related crisis services being the next. This slide here demonstrates a little bit about one relatively small grant program we have that is used to stimulate the development of mobile crisis teams across the country. We currently have 25 of these grants that support mobile crisis development across the country. They typically have, or our preferred staffing of these is a mental health professional together with a different type of mental health professional or a peer support specialist. So it's a pair that goes out in unmarked vehicles. Some of the communities do, instead of the complete civilian response, have a response that includes law enforcement, generally non-uniformed and non-armed law enforcement partnered with some other configuration of behavioral health trained individual. But we're clear that we prefer complete civilian responses. And so far, we've had very good luck with that. Some situations that you can imagine, you might say, well, is it safe to send non-armed individuals to certain of these situations? And it turns out that yes, in fact, the triage teams are pretty good at sorting out what might be an unsafe situation that would require law enforcement, armed and uniformed law enforcement versus a civilian response. It turns out we're pretty good at that. So that's been a myth that we've dispelled, I think you'd say, over time. Next slide. One of the other things that we've been working on at CMHS, led by Dr. Belina Shaw, is that supports the development of crisis services systems, is local behavioral health crisis mapping policy academies. And so what these do is bring teams together from local entities, often it's counties, but sometimes it's city governments or other entities that come together and sort of map out in a manner that would be similar to how you might map out a sequential intercept model in the forensic or criminal justice space. They map out what's currently available, where they'd like to go, where their gaps are in their community, starting from the perspective of the person in need of services, and build a plan. They're exposed to national experts when they come together and go home, take that plan back with them and build out that plan. Next slide. We did get, so the public comment's been very helpful for us all along the way. From the beginning of it, the very beginning of ISMIC, we've gotten quite a bit of public comment, which is we welcome. And in response to one of the public commenters that we had that was concerned that we had abandoned the SMI population because we did not have a technical assistance center, or the term of the grant expired, and there was a gap between when that grant expired and when we began working on or were able to, in a position where we could announce the contract that we now have that picks up the work of what was previously called the SMI Advisor, and now we're calling the Technical Training Assistance Center SMITA Center, basically. So we plan for this to be even more robust than the very successful SMI Advisor was, and are very grateful for the partnership that we had for many years with the American Psychiatric Association. And now the grantee is the National Council on Community Behavioral Health. Next slide. One of the other projects that we've been working on that could relate to the needs of individuals with serious mental illness and children with serious emotional disturbance is a project that we engaged the National Academy of Science, Engineering, and Medicine, previously known as the National Academy of, there is a NAM, a National Academy of Medicine. It's a component of the National Academy of Sciences. They merged together. We commissioned with them together, working with CMS, closely with CMS, a 1.5-year long study that looked at what suggestions they might come up with that would, or recommendations, this body that functions independently once the ask is worked out, functions independently of national experts, and they make recommendations with regards to what we might do to enable more of the whole spectrum of providers, behavioral health providers, to work with public payers, to work with, in other words, Medicaid, Medicare, and the marketplace insurance plan. We know far too many professionals don't accept public payer or public payment as a part of that, particularly those that are in outpatient settings. We also learned in that journey through observing the process as the National Academy rolled it out, that many training programs, or very few training programs, actually give exposure to their trainees to working with individuals with high complex needs, such as you commonly see with the Medicaid population, which often are involved in many of the issues that relate to social determinants of health. And so we plan to be pretty aggressive in working out some of the recommendations that were made from this report. The next slide demonstrates a little bit about those findings. The report's available, and I don't know if this is a violation of Dr. Delphine-Rittman's wish, but we don't have a QR code here, but we'll get one. The next time, she's very, very, very demanding, let's just say, about QR codes, so we'll get one.
Clearly, I don't get out much, right? So these are some of the findings that have to do with, of course, reimbursement rates. Many of us are familiar with that as a problem, but that's not the only problem. That's not the only reason that professionals choose not to accept Medicaid, Medicare, and marketplace plans in their settings. The reimbursement structures, the barriers that have to do with getting involved in signing up for or becoming paneled with various of the different aspects, the variability across states, the loss in some states of an advantage that we saw during the pandemic, which was a reciprocity across state lines when the Stafford Act, which declares the national emergency, was enacted. And now that that's gone away, many state departments have decided, or many state Medicaid offices have decided they would prefer not to have that sustained moving forward. And so that was one of the other recommendations, that there be greater emphasis on state compacts or encouraging states to enable professionals to work across state lines. Next slide. This is just a summary of those recommendations. Again, kind of long for us to go, and I've summarized a few of them at a high level, but I won't go into some of the details of these right now. But this is a very valuable report that some of us who are, policy nerds with regards to having a set of recommendations like at the beginning of ISMIC, this gives us a roadmap to look at what we might do to increase the capacity overall of behavioral health professionals to serve individuals across the spectrum, particularly those who are beneficiaries of Medicaid, Medicare, and marketplace coverage. Next slide. So I do want to thank you. Dr. Delphine-Rittman, I was going to talk a little bit about our social media TA Center, but Dr. Delphine-Rittman has talked about that already, but I did want to let you know that we've got copies of a handout that was given that does have a QR code on it that we'll leave in the back of the room for anyone who wants a one-pager on the social media that was developed. It's a work product of that task force that she referenced, and also of the TA Center that we have, another example of how we're using our technical assistance opportunities to create things that are useful to the general public. And so I want to call your attention to that. So thank you. I think many of us are at a period where we're, wondering sometimes, as I reflect at the beginning of this morning, there were some original ISMIC members that had been with us through the entire 8-year journey. And I think myself, and I guess that I'm biased, but I think there are many things that are attributed directly and or indirectly to ISMIC over the last 8 years. And I really feel very proud of the type of added value or public value that the convening, this privilege that we have to be on this convening that keeps us accountable to those with SMI and SCD provides. So I do want to thank everybody for their, as Dr. Delphine mentioned, your time and talent dedicated to us and keeping this intact so that it keeps us focused on the needs of those with SCD and also with SMI. So thank you. All right, thank you so much. And so I actually am going to step out for about an hour, probably a little bit less. And then Anita, if you can continue on with and then we'll next turn the mic over to Dr. Shaw. I'll be right back. It's actually a fun thing. We have a Halloween door decorating contest. And so I have to go judge 9 entries. I'll take pictures so you can see them. All right, I'll be right back.
Nice. Thank you. Yeah. So I will say that Dr. Shaw's been with us now for several years on this project is at its helm, working together with Joel and Pam, of course, who's our DFO. But I want to thank you, Belinda, now for all the work that you've done to help us keep ISMIC alive and well and progressing. So thank you.
Thank you. And thank you to Joel as well for making sure that I haven't broken any government equipment with trying to make sure that this meeting comes up, because there's a lot of technicalities behind the scenes, and Joel just makes sure that the trains are continuing to run on track. I'm very thankful.
Yep. Thank you, Belina. So for those of you who don't know me, I'm Joel, I'm a public health advisor here at the Center for Mental Health Services. And as you know, there's a lot of exciting stuff going on with the ISMIC. And here's just a quick preview of our updates. And please note that at lunch, we will be taking a group photo in the atrium. So make sure you fix your hair. So first I'll start with some steward changes. So very excited to announce our first non-SAMHSA steward actually, which is Sandy Resnick at the back of the room. She's joined Group 1. We also want to welcome Katie Hager, who's joined our criminal justice group, and of course, Michael Watterson, who's online, who has joined our finance group. And then, of course, we want to extend a special thank you to Maya and Peggy, who have been, very faithful stewards and are transitioning off. Also want to note that ISMIC member Joanna Candle has completed her term.
So the ISMIC report, so you guys have all gotten a copy of the booklet on your way in, or it was at the table. Just thank you all for your participation in getting this document up and off the ground. We have titled it Building on Progress, Federal Action for a System that Works for All People Living with SMI and SED, their families and caregivers. We have really framed this document to be not only just a list of recommendations, but this document is also a very user-friendly introduction to the ISMIC itself, so that if you just pick this up, you can understand what the ISMIC is, what are these, governmentees terms of SMI and SED, and what does that mean in a very practical manner. And we were very careful to think about, even as we introduced what the ISMIC was, that we have a mention of the public comment and reminding ourselves that that is a part of what we do. We then have some summaries of the major advances in the field. And these are, this was a congressional request, but we've also made sure that we've touched on how these congressional advances relate to the work that is being done in the government broadly as well, and how we have interfaced with the public growth and expansion of the space. And then we move on to the recommendations, and the 2024 recommendations are quite similar to the recommendations that those of you who have been around from the very beginning are aware of and have started, and really just built upon maybe some modifications. But this is a great place now to have all of the specific language that is consistent and will be the formal recommendations here. And then we have those broken out by working groups as well. And then in this document, we have now rebranded. The ISMIC is not SAMHSA. So, that HHS logo with SAMHSA, we felt was inappropriate for placing on this document. SAMHSA, the ISMIC is truly a federal advisory committee that has multiple agencies that are explicitly stated in statute, as well as roles of private citizens as well. That are explicitly stated. And so we wanted to make sure that not only is this not just looking like this as another work of SAMHSA, but that also that we're highlighting the work of the working groups. From the very beginning, that these recommendations have been categorized into these essentially 5 working groups, and we wanted to highlight them. So I'll just go over again what the logo it represents, and also then we'll be revealing here the logos for the small working groups. So the core color is purple. The purple is indicating recovery, and you will see that the whole report has been thematically designed around the color purple. And I know that recovery was one of those words that came up in the beginning a lot as well. And in the center, you'll see that inner ring, and those inner circle have the 3 little dots and outstretched armed people that are indicated that those people are together in community, but they're also connected to the outer rings as well. And then those outer rings have colors, and those colors are indicative of our 5 working groups. So you'll see that the treatment and recovery working group has that logo there, and that's blue, and each of those colors is consistent with one of the rings, and the logo has been designed to reflect the work of the working group. Just like Anita said, there has been a lot of work that hasn't always been clearly attributed to the ISMIC, and the goal of this was to make sure that we can clearly indicate that some of the work that has been done, whether or not it's in SAMHSA or other agencies, can tie back to what the ISMIC has been doing, or that there has been some thought leadership from the ISMIC in its development. So we were very thoughtful about creating that.
Alrighty, thank you, Belina. So as you may have noticed, the ISMIC website has undergone some significant changes, and so we're really excited to announce that our videos available of our past recordings, including this one, will be available on our website. We've begun the release of a quarterly newsletter to share resources and provide updates to our ISMIC membership on a regular basis. And of course, we have our SAMHSA website where we include resources for both clinicians, practitioners, people with lived experience, and the public to peruse. And one final note I will make is to save the date. We're excited to announce our ISMIC Spring meeting will be on March 19th, 2025. And with that, I'm excited to introduce our next section of the agenda, which is our SAMHSA suicide prevention and crisis guidance updates. We will be hearing from Captain David Berry and Dr. Belina Shaw. So Captain Berry, please take it away.
Sure, you can go to the next slide. So I'm going to be providing a 30,000-foot view. Is it off?
Just a little closer because the transcriptions, maybe pull it behind the your name tag.
How's that? Okay. So I'm going to be providing a 30,000-foot view of the NSSP, the National Strategy for Suicide Prevention. I have about 10 minutes. So really, I'm going to give a little bit of a plug is to go and actually take a look at both the NSSP and the related federal action plan online. We do not have a QR code for it. We do have a few hard copies in the back. It is on the SAMHSA website, but also if you Google NSSP and suicide, it's one of the top things that shows up. So it's easy to find. So the NSSP was released this year in April 2024. It incorporates a wide variety of recommendations and directions in the field, actually modernizing our approach to suicide prevention and including topics that are relevant today that may not have been as relevant when the initial NSSP was written back in 2012 and then assessed in 2017. It really incorporates these advancements. It's designed to be a guide, to motivate, to really promote coordinated suicide prevention. You'll see as you're looking through this and some of the things that are going to be mentioned, there's a real strong community focus to the NSSP. That came from the 2017 recommendation as well. And really that is where a good portion of the suicide prevention happens is at the community level. We could do things at all levels, but that's where rubber is meeting the road. And it focuses on addressing the risk factors and protective factors associated with suicide prevention and recognizing that there's not one silver bullet that is going to get at the heart of suicide prevention. It needs to be a multi-pronged approach that is on all levels. So this is a bold 10-year plan for the NSSP, and the federal action plan is a 3-year plan, which I'll get to in a little bit. Next slide, please. So really, we just want to share that the NSSP was not done in isolation. And I have another slide showing all the different federal agencies that are part. And this is some of our key contributors here with the SPRC, the National Action Alliance, SAMHSA, CDC, NIMH, and ASPE. I do want to say that we did have one of our champions of SAMHSA, who was one of the co-authors of the NSSP, Brandon Johnson, who unfortunately was not able to be here today. He's on travel. But I do want to give a little shout out for him for the CDC for really putting a lot of pen to paper and doing a lot of the higher level program management elements that go along with this. Next slide, please. So the NSSP was not done in isolation, nor was it just done with our federal partners. It was done with lived experience. It was done by reaching out to communities. It was done by looking at all the previous reports and recommendations. It was tried to be done in a very comprehensive, thoughtful way, because the thought and hope would be here is that when communities, providers, different program directors, states, federal agencies are working on this, they're looking at it and the NSSP resonates with them on many different levels. So just pointing out that we had the NSSP is based on the VA's National Strategy for Suicide Prevention. There was an advisory group for social media and youth mental health. It's based on Surgeon General's previous calls, the one that's here mentioned in 2021, but also previous ones. And it also focuses on elements from the behavioral health crisis guides, from national guidelines, and from other preventing suicide reports. So next slide, please. So, so the NSSP is, like I was saying, is a 10-year plan. The hope would be is that we are using this, and then after the 10 years is over, we are going to take a look at the NSSP and see how relevant for us what it would be in 2034. The NSSP, as I mentioned, just really focuses on the lived experience. There's an emphasis on tribal members, youth, suicide prevention, and really there's, and I'll mention there's a whole section on equity, which was not necessarily focused on the previous NSSPs, where we are really addressing those at-risk populations. Next slide, please. So here is just a snapshot of the interagency work group and federal contributors. I'm not going to go to this, but it's just give you an idea that this is not something that was done in isolation. So next slide, please. So just give a brief updates for this, where we are now versus where we are from the 2012. We did not discard the 2012. The 2012 NSSP has a lot of great work, and the 2017 evaluation indicated that since the 2012 NSSP came out, suicide prevention efforts have greatly increased. And there's a lot of still great information there, but it needs to be modernized. So what we did is we created a new strategic direction focusing on equity. We strengthened and focused on upstream prevention and comprehensive approaches. We reflected advancements in surveillance. There are new goals addressing 988, which is new, lethal means, workplace suicide prevention efforts, focusing on states, tribes, communities, territories. We're also looking at things that are much more relevant now than were before, social media and digital technology. This is something where there are opportunities to be able to reach individuals, but also recognizing that social media also has the potential to provide some harm level as well. We look at substance use and adverse child experiences, and really we're aiming to strengthen the objectives for community care with that, and focusing on that with continuity, care transitions, and provider training. And we're also elevating this strategy throughout the objectives, and that we'll talk a little bit about in the national strategy coming up right now. So next slide, please. So the national strategy, unlike the previous one, is actually broken out into 4 strategic directions. The 4 strategic directions are community-based suicide prevention, and this is a comprehensive approach to suicide that calls for communities to select and evaluate a range of strategies to address many factors associated with suicide. It's at the individual, it's with relationships, with communities, with families, with societies. And the strategic direction 1, requires that upstream prevention. And we're looking at lethal means, reducing those for risk, looking at other risk factors, workplace strategy, evidence-based informed communication, and messaging. The second strategic direction, treatment in crisis, is a lot like what it sounds like. It's aiming on preventing suicide that requires making sure that those that are at risk for suicide are getting connected to proper treatment and to the services they need. So a lot of this focuses on crisis care continuums, having access to services that are 24/7, having providers that are very knowledgeable at being able to address suicide. This is at peer support and many different levels from that individuals will experience, whether they're in a behavioral health psychologist or social worker's office, or going to their primary care doc, or they're working with or living within their communities. The third one is surveillance, quality, and improvement. This is really just a focus on understanding that for us to understand the direction going forward, we need good quality data to enable evaluation of suicide prevention efforts. So this section here really emphasizes the need to be applying research to advance, to improve, but also to be monitoring and tracking how suicide prevention efforts are happening, not only just at the federal level, but at the community level as well. And as I mentioned before, strategic direction 4 is a focus on health equity. There is a look at those populations that are risk. It is looking at the individual needs and looking at people as individuals and trying to meet them where they are, knowing that each person is part of a community, but also has their own complex needs and experiences, and addressing them on that level, and also making sure that we are addressing populations that are disproportionately impacted by suicide. Next slide, please. So strategic direction 1 goals, and this kind of dovetails to what I was just saying there. And I won't necessarily read all these because you could see, and I'll just pause a little bit so you can take a look at them. The community-based suicide prevention. And, you know, there's a couple here I think that are really worth pointing out is that, you know, it's there collaborative. We mentioned that earlier today. It's, you know, community-based. It's reducing risk. It's integrating suicide prevention into culture, into the workplace and community settings. It's to be building and sustaining suicide prevention infrastructures at all different levels, and to implement research-informed suicide prevention communication activities. So, and I really encourage you to please check out the NSSP online. Like I said, this is just a gloss over of where things are. Please go to the next slide before we could just really mention 2 and 3. So we're looking at for strategic 2, this is, you know, suicide prevention is an essential component of healthcare. And it's something that we should be addressing on all levels with competence, comfortableness, and an ability to be able to help the individual regardless of where they are. It's also for improving quality, accessibility, and crisis care services across all communities. And for 3, as mentioned before, it's really that focus on research and looking at evaluating of suicide prevention efforts so we can continue to improve and learn from our efforts that are ongoing within the communities. Strategic prevention number 4 on the next slide, thank you. Really, it embeds health equity into the suicide prevention efforts. It is a means for comprehensive suicide prevention strategies for populations, as mentioned before, that are disproportionately affected by suicide, and create an equitable and diverse suicide prevention workforce, and improve and expand effective suicide prevention programs for those individuals that are at risk. So briefly going to the Federal Action Plan. So the Federal Action Plan, and Dr. Delphin Rittman mentioned this, there are over 200 actions. There are goals and objectives within the Federal Action Plan. And we do have some copies of this Blue Book and the NSSP that are over here. So if you look through this, the Federal Action Plan, next slide, please, really has a listing of this is what the goal is, this is what the objective is, and here are some actionable items that you could do. So the Federal Action Plan to me is a way for us as a federal agency to operationalize the NSSP and be able to really look at how we could be engaging things at our level to be able to ultimately promote community and suicide prevention across the country. So just within the Federal Action Plan, I'm not going to necessarily read these. There are, sample actions that are called out. So for like the VA, the recommendation there is design and implement toolkits for working with specific veteran populations at disproportionate risk. These Federal Action Plan goals and objectives were not done in isolation. It's not like the authors put this together and said, okay, VA, do this. This was done in that collaborative approach with the VA, identifying these goals. The same thing for NIH and CDC. Next slide, please. And there we also have some others for IHS, SAMHSA, and USDA here. So this was done in that level of coordination, and the hope would be is that this Federal Action Plan, which is based on 3 years, that at the end of 3 years, we will be able to be meeting these goals and objectives. Last slide, please. So really the next slide is dovetail, just saying, is what we were looking to do is to really implement that Federal Action Plan at the federal level and to promote the NSSP usage, not only just at the federal level, but at all levels within the country and at the community level. So I'm being told I am done. So I will pass it over to Belita.
There were no covert hand signals or anything.
It was facial expressions.
All right. And so I'm just going to talk a little bit about some of the updated guidance in the crisis continuum, in the crisis space. And you might be asking, why are we going over some of these explicit updates? But I want to bring us back to our handy book. And if we look at page 33, for example, 2.1, recommendation 2.1 is define and implement a national standard for crisis care. And if we also say, look at page 35 at 3.7, that there's the advance the national adoption of effective suicide prevention strategies. So, this is all tied back to what we do. And even I think there was another one, even the SMI advisor, for example, 310, develop a national and state capacity to disseminate and support implementation of national standards for a comprehensive continuum of effective care for people with SMI and SED.
Yep. And I just will say, for relatively new members of ISMIC, these recommendations we've pretty much retained over the 8 years. A few that we've edited along the way, but pretty much. So they, you can sort of figure out for yourself how much you think that they were. I would, I think we those have been working on the project believe this was very fundamental in shaping a lot of the priorities that we've taken on over the last 8 years.
And I would also like to say that I know some of our stewards have been with the ISMIC since the beginning. And as far as thanks as well, there's that adage that if you want something done, to give it to a busy person. So when you see that idiom and you Google it, you see the ISMIC logo next to it, right? I mean, that is basically, we have some of our busiest managerial leaders here at SAMHSA and now at the VA that have been leading these working groups to really continue to steer and guide the work. And so we're just thankful to our staff that continue to make this happen. This work does not happen in a vacuum, and even just the air traffic control and the support of the report and the details of the edits of the report and making sure that it's all accurate. You guys have all been a great team to work with since starting. So just thanks to the stewards as well. So we are going to go over just some of what's happening in this crisis continuum space to work on implementation of recommendation 2.1. And there's 3 major lines of work that are ongoing right now. Then the national guidelines, the crisis national guidelines 2.0, there were the 2020 guidelines that are still like the last I heard the 5th most commonly downloaded document in the SAMHSA store or something like that. It's very, very important document and Sentinel implementation of 2.1 and continuing to now in this to update that in this post 988 world and that's ever evolving. And really at the foundation of all of this is these model definitions and standards for the crisis continuum as well. And so that we can now, when we talk, when we talk about what is a mobile crisis team or a crisis stabilization facility, that we will be able to have a shared nomenclature for what these things are. And then also we will have our first implementation guidance document of these standards and definitions and how to pull that all together in the national guidelines with the mobile crisis toolkit that's still under development. And so why did we do this is because every state, county, community has really just figured out that crisis care is important and tried to do their best to pull together what they could, but it's now not consistent. There's inconsistent use of terms, and the challenge with that inconsistency is the inability to really establish quality metrics, have expectations for what each level of care is required, for people to know how to navigate these systems, and also for people to get paid for the work that's being done. If you call 2 things that are the same thing, but they're doing very different levels of work with different degrees of intensity, then they need to be compensated in a commensurate manner, and we're unable to do that without some standardization across the space. And so we have been refining these proposed definitions and standards based on the three main pillars that you've previously heard of: someone to call, someone to come to you, and a place to go, which Anita did coin that term in the very beginning with David Covington together, I'm sure. And so, you guys have, are sort of these foundational leaders in this space. And it's continued to evolve. Someone to contact being a blend of now knowing that text and chat especially is so highly used among young people, and we didn't want to just say someone to call, knowing that we have the importance of the other modalities, someone to respond, because I guess we like SAT words, and then a safe place for help. But a safe place for help, knowing that especially when we think about youth, that home-based stabilization can be a very important stabilization setting, and that our youth advocates did have strong feelings about the use of the term "go," because we do know that being at home as much as possible and safely as possible is developmentally what's best for that stabilization. So a safe place for help, to generalize that. And so we are doing this work in coordination with the 988 and Behavioral Health Crisis Coordinating Office, also with the Center for Substance Abuse Treatment as well, and just together figuring out how these needs can meet the nation, mental health and substance use together. Next slide. And so here's a picture of some of the working group. And just the point of this picture is that this is one of many that say that like this specific federal advisory committee, we did not do this in a vacuum. We wanted to think about and see how do we use the knowledge of experts in this very burgeoning and developing field. And really the goal is to balance the vision with the current state of the crisis continuum, to not disassemble what has happened already in this very organic growth, align with what are national existing standards, but also knowing that we might want to modify and not necessarily adhere to every tenet of them, and then honor the voices of partners, although we know that full consensus will never be fully possible. And so we have been doing this work for about 6 months or so. And the key here is that we do, we are submitting some of these drafts now for internal clearance, and working towards getting them cleared for a public comment period as soon as possible, with the goal of getting this done by the end of the year or very early next year at the latest. And so now you will see here that there's a categorization process, and that there's these three main essential elements: the contacting, responding, and safe place for help. And then also under there, especially in category 3, you'll see that crisis stabilization services, there are different levels of care, levels of intensity, and that they can include stabilization units, but also residential programs, peer respite, urgent care, home-based stabilization. There are lots of different stabilization types that can occur, and including sobering centers, just entities that we haven't necessarily thought of, that are low barrier but can be very helpful here. And all of this is quite subject to change, as all of it's still under development. So the national guidelines, we like to think about the base circle there as being kind of what the puzzle pieces look like and what those shapes are and how they're formed, and that the national guidelines are taking those system components and creating and putting together a puzzle with the different pieces. And there's been some landscape work that has been done with NASHBID, and thanks to Brian and who I know is online, through McKinsey, about what are some landscape scans based on the Transformation Transfer Initiative, states that have been doing this work, literature review, best and promising practices, and state and local examples to really think about practice-based evidence in this growing and emerging field. And then there's also another convening as well for this work. You see some familiar faces in there too. Hi, David. And so we have some overarching principles for the work, that this was for the guidelines, that this work will be at a systems-based approach, person-centered, family-focused, and providing the right level of care at the right time. We like to think of sort of the Goldilocks approach, not too much, not too little, and having communities have what they need so that we are being most inclusive and least restrictive at all times. Safety between suicide safety, overdose safety, but then also safety from the perspective of the person who's seeking care. Effective and high quality, equitable, recovery-oriented, trauma-informed, evidence-based, informed, or reflect the recommended practices, developmentally appropriate and responsive to multiple needs. That's including that multiple needs is not super clear there, but thinking about physical health needs, especially those who might have, say, intellectual and developmental disabilities, or just other needs that are often exclusionary criteria to crisis care. Next slide. And then we are thinking about this coordinated crisis systems of care. I think as of an hour ago, it might be coordinated system of crisis care. We said this is all under flux, but either at the end of the day, we think that these are some core areas that are required to really be built and developed, and that an accountable entity of some sort is going to be really important to steer the development of this work at a systems-based approach. And we really want to lean in to the systems-based approach in the next set of guidelines. And so we have developed draft documents and had these group discussions, and we're incorporating all of our feedback, and it's in internal clearance now, or we're working on getting it towards internal clearance as well. And then the public comment will be following thereafter as well. Next slide. So I think that I tried to get us back on time. We have about 5 or so minutes for sort of discussion generally about all of the SAMHSA updates that you've heard, because there was a lot. But as we thought about how we framed the agenda, you guys are a federal advisory committee, and this is the work that the federal government is doing. And we wanted to make sure that you were aware of that work. And if you had any questions, comments, feedback about this work that is related to the recommendations and impact that you have.
And we're monitoring the online folks. So just if you'll raise your hand at the bottom down there, that would be helpful. We'll call on you as well if you have any questions or comments.
Or did everyone have coffee and they're ready for a bio break? All right.
It's a speechless group this morning. Okay. Oh, wait a minute. Oh no, the green. Oh, Sean.
No, I actually didn't mean to raise my hand. I apologize.
Okay. You were ready for a bio break, but you're at home, so.
Yeah, but I know. I'm cheating. Sorry.
That's okay. That's okay. All right, David.
Just one brief comment. We're talking about the success of this group and the work that's been done. When we started in 2017, we had not seen a reduction in the overdose death rate since '99. There was a brief blip in 2018, but it's way too high, but we saw upwards of 10% reduction in the 24 report, which is the bending of that curve that we've all been working so hard to impact for so long. To see that kind of was a lot of positive. So we're talking about the success of what SAMHSA is doing, and the NISDA report. That was a remarkable move to see finally starting to make real impact with that, and want to see the same work as we talk about the National Strategy for Suicide Prevention and that data as we continue to lean on that curve as well.
I do have one question, if I may. Jennifer Higgins here. Can you hear me? Okay. The 988 data, will that ever be publicly available? Do you know?
So there is a dashboard that's online.
Oh, it is already online. Okay, great. Thank you.
It's updated pretty regularly, so you can find out number of calls, duration, call time that takes to answer the phone, and the types of diversity that people select. By that I mean there's some sublines that are set up for Spanish-speaking individuals, LGBTQI individuals, and veterans, of course, and a video phone, for ASL. So yeah, all the statistics are online.
And actually David reminded me as well that in the back of the report, there's an inventory of all of the work that has been done by all of the agencies. And that, you know, the SAMHSA staff and now we're expanding to other agencies have been working as stewards. But, you know, all of the federal agencies have had a part and played the role in this and have shared data and some key programmatic data points of all the programs that are related to this population and really some exemplar programs in a specific spotlight. And we're definitely thankful for that. And I think it once again shows all the work that's been done and is doing, and also to all of those folks for helping to get that information in and cleared as well. I think we can go to the restroom.
Okay, so yeah, let's do. Before that, I do want to take just a little bit of a point of privilege, and I want to recognize Kristen Painter sitting over there. Kristen, will you raise your hand? Sorry. Because Kristen's been with us since the very beginning. She worked at one point at SAMHSA and now is working at at NIDLR for disability research. It's a section of ACL, and is going to be retiring in a couple weeks. And so she's here as a not a last hurrah, but a sort of a semi-last hurrah to join us together. And I just, if you'll say hello or take a minute maybe to congratulate Kristen on many years of public service. And then so I think, shall we take the full 15 minutes in and be back at 5 till 11 and turn over the place to the lawyers who are important friends in the work that we do, all of us in the mental health space. Thank you.
I hope everybody had a good break. I'm really excited about this next session. As you know, I think as many of you probably know, there were final rules put out for the implementation of parity just a couple months ago. And this is really exciting development in our field. Improved enforcement of parity and improved implementation of parity, I think directly results in better access to services. And we all know that anything we can do to improve access at this point is really important given the trends that we see in our field. So we have a couple people here to speak about parity. These are some of the people who know the most about it of anybody in the country. So I think we're really happy to have them join us here today. They are regular participants in the financing subcommittee of the ISMIC. There's one quick fix on the agenda. You see Dina Fox is listed under this. She's actually going to be a presenter under the financing work group. She's not under this section. So Dina's not going to be talking about parity. She's not a parity expert. She's an Olmstead expert. She's going to be talking about Olmstead. Also very exciting. But we are going to be hearing in this session from Beth Baum from the Employee Benefits and Security Administration of the Department of Labor, Jacob Ackerman from the Center for Consumer Information and Insurance Oversight at the Centers for Medicare and Medicaid Services, and then Kirsten Baroni, who works also at CMS with the Centers for Medicaid and CHIP Services. But all three people who have really deep background in parity, and you're hearing it directly from the folks who really work directly on these issues. So I'll turn it over to, I think, Beth, who's going to kick it off.
Thank you so much. Can everybody hear me?
Yes.
Okay, perfect. Well, thanks for having us today. I think it was around this time last year, we were at the ISMIC meeting and talking about the proposed rules that we had put out last summer. And so now we're back with final rules that we put out last month. When we put out the proposed rules, we got over 9,500 comments. And most of those comments were not brief. We got a lot of comments that were 20, 30, 40 pages long with a lot of detail, which we really appreciated. And we are happy to have published these final rules. They have two aims. First, to strengthen the existing parity requirements that are finalized in the 2013 final rules under the Mental Health Parity and Addiction Equity Act, or MAPIA. And so we've strengthened some of those existing requirements, particularly with respect to non-quantitative treatment limitations, or NQTLs, which I'll talk about in more detail. And then the rules also provide guidance to group health plans and health insurance issuers on the requirement to perform and document comparative analyses types of NQTLs that apply to mental health or substance use disorder benefits, which is required under amendments made to MAPIA by the Consolidated Appropriations Act 2021. So I'm going to walk through some of the highlights of the final rules. We could talk for much longer than we have today about all the details of parity. My agency did do a recorded webinar that we held in September shortly after the rules were released. So if you are really excited about parity like I am and you want to take 75 minutes and really learn more about the ins and outs, I'll try to put that the link to that recorded webinar in the chat at the end of the talk today. So starting with the amendments to the existing MAPIA regulations to strengthen them, one provision that we included was the addition of a purpose section. And this was added to reiterate that the fundamental purpose of parity is to ensure that individuals don't face more restrictive limitations or requirements when accessing mental health or substance use disorder benefits as compared to medical surgical benefits. And the purpose section I think of as the moral compass of the rules. It's meant to guide plans and issuers as they work to comply and make sure that they keep that person in mind when they're complying with all of the different requirements under the regulations. Next is the definition section. We made some changes to existing definitions and we added some new defined terms. I'm not going to go through all of them in detail, but wanted to highlight a couple different groups of definitions. The first is the definitions of three terms: medical surgical benefits, mental health benefits, and substance use disorder benefits. Plans and issuers have to, before they can determine compliance with parity, know what is considered medical surgical and what is mental health or substance use disorder benefits, so they know what they're comparing on each side of the parity analysis. And the changes we made to the in the final rules retain some of the flexibility that plans and issuers have had since 2013 with how they define these different types of benefits, but stresses that that discretion has to be exercised in a manner that comports with generally recognized independent standards of current medical practice. And so for purposes of defining a condition, disorder, or procedure as being mental health, substance use disorder, or medical surgical benefits, the plan or issuer is required under the final rules to follow the most current version of the International Classification of Diseases, the ICD, or the Diagnostic and Statistical Manual of Mental Disorders, the DSM. We also have new definitions of ICD and DSM that provide details on what is the most current version of each resource as of the effective date of the rules next month, and when a new version must be followed. The other thing I'll point out with these definitions is that the preamble to the final rules notes that eating disorders, autism spectrum disorder, and gender dysphoria are all considered mental health conditions for purposes of parity. The other definitions I wanted to highlight very quickly are new definitions that we added in the final rules. These are terms that are contained in the text of the 2013 final rules and the Consolidated Appropriations Act 2021. So I'll talk a little bit about that in just a minute, but the existing MAPIA rules that are currently applicable today require for non-quantitative treatment limitations that parity be analyzed by looking at the processes, strategies, evidentiary standards, and other factors that are used to apply an NQTL to mental health and substance use disorder benefits, and ensure that they're comparable to and not applied more stringently than the same processes, strategies, evidentiary standards, and other factors that are used to apply the NQTL to medical surgical benefits. And so we've added definitions of those 4 terms in the final rules to make sure everyone's speaking the same language, whether it's the plans and issuers who are performing and documenting their comparative analyses, or the departments or applicable state authorities that are reviewing them. So I want to spend some time getting into some detail on the requirements for non-quantitative treatment limitations, or NQTLs. The overall framework in the regulations has an overarching requirement that we call the no more restrictive requirement. It's very similar to the exact statutory language in MAPIA that applies to treatment limitations, including NQTLs. And under the rules, to comply with the overarching requirement, plans and issuers have to comply with 2 sets of rules. There are the design and application requirements and the relevant data evaluation requirements. And I'll talk about both. The first is the design and application requirements, and this has 2 components in the final rules. I just talked a little bit about the first requirement, which is the general rule of the design and application requirements. And again, that looks at the processes, strategies, evidentiary standards, and other factors used in designing and applying an NQTL to mental health and substance use disorder benefits and medical surgical benefits. But previously and currently under the 2013 final rules, there were no restrictions or limits on the types of processes, strategies, evidentiary standards, and factors that could be used in applying an NQTL or designing it. So the final rules add new requirements that prohibit the use of any discriminatory factors, which include processes and strategies, or evidentiary standards when a plan or issuer is designing an NQTL that's going to be imposed on mental health or substance use disorder benefits. So this is really a threshold question before you get to the general rule and you're comparing what's used on the mental health side and substance use disorder side to what's happening on the medical surgical side. The plan or issuer first has to make sure that none of their factors or evidentiary standards are discriminatory. And for purposes of the rule, a factor or evidentiary standard is discriminatory if the underlying information, evidence, sources, or standards on which it's based are biased or not objective in a manner that discriminates against mental health or substance use disorder benefits as compared to medical surgical benefits. So the rules really require plans and issuers to drill down on each factor and evidentiary standard and look at what it's based on. And so as a plan or issuer is doing that, they're going to look at all the relevant facts and circumstances to determine whether information is biased or not objective. And they're going to look at this through the lens of whether the information, evidence, sources, or standards systematically disfavor or are specifically designed to disfavor access to mental health or substance use disorder benefits as compared to medical surgical benefits. The other provision that's relevant here that we added in the final rules, which was not in the proposal, was if a plan or issuer does the analysis of the underlying information, evidence, sources, or standards, and they determine that their factor or evidentiary standard that's used to design the NQTL is discriminatory, they can take steps to correct, cure, or supplement anything that starts out as biased or not objective. And if the information is no longer biased and it is now objective, it can be relied upon. The last couple notes on this part of the design and application requirements are some examples that we included in the final rules. We said that historical plan data or other historical information from a time when a plan or coverage was not subject to MAPIA or was not in compliance with MAPIA is generally going to be considered biased or not objective. If it systematically disfavors access or is specifically designed to disfavor access, as long as the plan has not taken the steps necessary to correct, cure, or supplement the data or information. And then for factors and evidentiary standards that are relying upon generally recognized independent professional medical or clinical standards or certain types of fraud and abuse measures, those are not generally going to be considered biased or not objective in a manner that makes them prohibited from being relied upon as a threshold question. But plans and issuers still have to ensure that if they're using factors and evidentiary standards that are based on those medical clinical standards or fraud and abuse measures, that they're comparable and not more stringent when they're used for mental health or substance use disorder benefits as compared to medical surgical benefits. So that's the first set of requirements for non-quantitative treatment limitations. The second set of requirements, which is new in the final rules, are what we call the relevant data evaluation requirements. And so while the prohibition on discriminatory factors and evidentiary standards was really focused on the application of the focused on the design of the NQTL, the data requirements are focused on application. So a planner issuer has to do three things here. They have to collect and evaluate relevant data. They have to determine whether the data suggests that the NQTL contributes to material differences in access to mental health or substance use disorder benefits as compared to medical surgical benefits. And then third, if there are material differences in access, the planner issuer has to take reasonable action as necessary to address those material differences to ensure compliance in operation with MAPIA. So for now, plans and issuers are going to determine for themselves what is relevant data. They cannot disregard any data that they know or reasonably should know, suggests that an NQTL is associated with material differences in access. And the departments do intend to issue additional guidance on the type, form, and manner of data to be collected and evaluated in the future. The next step after the relevant collecting and evaluating relevant data is material differences. So to the extent that the relevant data that's evaluated suggests that the NQTL itself is contributing to material differences in access to mental health or substance use disorder benefits as compared to medical surgical benefits, that's going to be considered a strong indicator of a MAPIA violation. And differences in access are material based on all the relevant facts and circumstances if the difference in the data suggests that the NQTL is likely to have a negative impact on access to mental health or substance use disorder benefits as compared to medical surgical benefits. If the differences in access shown in the data are attributable not to the NQTL, but to reliance on generally recognized independent professional medical or clinical standards, or certain fraud and abuse measures that are really carefully circumscribed to detect, prevent, or prove fraud and abuse without being too broad in a manner that really restricts access to benefits, those are not going to be considered material differences, and those would not require reasonable action. If there are material differences in access that are attributable to the NQTL, the final rules require plans and issuers to take action as necessary, reasonable action, to address those differences to ensure compliance with MAPIA in operation. And a planner issuer will ultimately determine what constitutes reasonable action and will need to document in their comparative analysis what reasonable actions they have taken or they are taking to address any material differences in access that exist. The comparative analysis also has to address any differences that persist despite any reasonable actions that have been or are being taken. And one final note on a certain subset of NQTLs that we are particularly focused on. These are NQTLs that relate to network composition. We said in the proposed rules that we were very concerned with these types of NQTLs in particular because the composition of a network can have such a direct impact on access to benefits. We previously proposed to hold these NQTLs to a higher standard, but in response to comments received on the proposed rules, we have not finalized that. However, network composition and QTLs are going to work a little bit differently under the data requirements. All the data for all network composition and QTLs will be collected and evaluated together, because it's a little hard to pick out which network composition and QTL might be responsible for this material difference than that NQTL. We also suggested some reasonable actions we would expect to see where there are material differences in access that are attributable to network composition and QTLs. Things like making special efforts to contract with a broad range of available mental health and substance use disorder providers, which may include greater compensation or other inducements, plans and issuers expanding telehealth arrangements to manage regional shortages, making sure that plans and issuers can get help finding in-network providers, and ensuring that network directories are accurate and reliable. So I know that's a lot of information. That's the main changes to the rules for NQTLs. I do want to highlight one other change that we made to the existing MAPIA regulations. Then I'll talk about comparative analyses and the effective dates. But the other change to strengthen the existing MAPIA requirements is what we're calling the meaningful benefits standard. The longstanding rule under the 2013 parity rules says that if a planner issuer provides any benefits for a mental health condition or substance use disorder in any one of the 6 benefits classifications that are used to analyze parity, the planner issuer has to provide benefits for that mental health condition or substance use disorder in every classification in which medical surgical benefits are provided. So it's really making sure that there's some parity in how the benefits are provided under the plan. And the meaningful benefits standard strengthens that requirement to ensure that plans and issuers are not providing the full range of medical surgical benefits and then providing the bare minimum, maybe only one or a few very isolated or ancillary mental health or substance use disorder benefits. So this is really requiring parity in terms of what benefits are offered. If a planner issuer is offering meaningful benefits for medical surgical conditions, it must offer meaningful benefits for mental health or substance use disorder benefits in each classification. And for this purpose, the term meaningful benefits is defined as a core treatment for a condition or disorder. We got some comments suggesting that we define meaningful benefits to be the primary treatment for a condition or disorder. And we heard also that there may not be one primary treatment for a condition or disorder. So we went with a core treatment to acknowledge that there may be more than one treatment and there may be no single treatment that would be considered meaningful for purposes of parity. And then so that's all of the changes to strengthen the existing MAPIA requirements, but we also published a new regulation on comparative analyses that are required under the Consolidated Appropriations Act 2021. We laid out details on the 6 content elements for those comparative analyses. We also outlined the process by which the departments will request and review a comparative analysis to make a determination of compliance or non-compliance. The departments are required to request and review not fewer than 20 comparative analyses per year. So this lays out the back and forth from the time a department requests a comparative analysis, reviews it, maybe asks for additional information, and provides the planner issuer with opportunities to respond before an initial determination of non-compliance and then potentially a final determination of non-compliance is issued. If a final determination is issued, a planner issuer must notify all participants, beneficiaries, and enrollees in the plan or coverage within 7 business days after the determination of non-compliance. So we have some specific content elements for that notice requirement. And another key thing to highlight with the comparative analyses is that the departments are not the only entities that can request copies. Plans and issuers also have to make copies available not only to state authorities upon request, like state insurance departments, but also to participants, beneficiaries, and enrollees. All of those, if they've received an adverse benefit determination, a denial of benefits in whole or in part for mental health or substance use disorder benefits. And then for ERISA plans, participants and beneficiaries in those plans may request a copy of a comparative analysis from their plan at any time. Very quickly to wrap up, and I'll turn this over to Kirsten. We also included in the tri-department rules an HHS only provision that sunset what we call the MAPIA opt-out. The Consolidated Appropriations Act of 2023 amended MAPIA so that self-funded non-federal governmental plans, which are mostly state and local government plans, who could previously elect to opt out of compliance with MAPIA are no longer permitted to do so. So HHS finalized some regulatory amendments to implement that sunset provision. And HHS also included provisions in the rules to apply the same standards in the MAPIA package for group health plans and group health insurance coverage in the individual market. Last thing I'll cover is applicability dates. For group health plans and group health insurance coverage, the final rules generally apply on the first day of the first plan year, beginning on or after January 1st, 2025. But the meaningful benefits standard, the prohibition on discriminatory factors and evidentiary standards, and the relevant data evaluation requirements, as well as any of the content elements related to those requirements in the provisions for comparative analyses, have a delayed effective date. So those requirements won't begin to apply until the first day of the first plan year, beginning on or after January 1st, 2026. And all of the final rules apply to health insurance issuers offering individual health insurance coverage for policy years beginning on or after January 1st of 2026. Until that applicability date kicks in, whether it's beginning in 2025 or in 2026, we expect that plans and issuers will continue to comply with the existing requirements, including the statutory requirements of MAPIA and the amendments made by the Consolidated Appropriations Act of 2021. So that's it from me. Jacob, I'm not sure if you wanted to chime in on anything, but otherwise I can turn it over to Kirsten.
Nothing for me. Thanks, Beth.
Great, thanks so much, Beth and Jacob. I am just gonna talk for a few minutes about the work we're doing in the Center for Medicaid and CHIP Services at CMS to ensure improved compliance with parity in Medicaid and CHIP. As you may know, we have a separate set of regulations that implement MAPIA in the Medicaid and CHIP programs that were finalized in 2016. So the recent actions we've taken are designed to implement and improve compliance with those regulations. What we've done most recently, been working very hard to develop some templates and instructional guides for states to document compliance with Medicaid and CHIP parity requirements. We posted these draft templates and instructional guides on September 9th on Medicaid.gov. And after I finish speaking, I will put links to all of these things in my in the chat. But just as a reminder, as you may know, most of the provisions of MAPIA apply to coverage provided to enrollees of Medicaid managed care organizations and coverage provided by Medicaid alternative benefit plans, which are mostly used for the Medicaid expansion population under the ACA, as well as separate CHIP programs and Medicaid expansion CHIP programs. For ABPs and separate CHIPs, it's actually regardless of managed care or fee-for-service, if the benefits are provided, and either way, parity applies. But because of how the statute links in parity requirements for Medicaid, those parity requirements for the general Medicaid population do not apply when benefits are provided only through a fee for service approach or through kind of specialized managed care plans called prepaid inpatient health plans or prepaid ambulatory health plans. But we have encouraged states to ensure compliance with parity across the board, and I think a lot of states do work in that on that. But with regard to the templates and guides, and these templates are very comprehensive, many tabs, lots of interactive functionalities. But they were posted or we've developed them and issued them for public comment to clarify for states and plans what information they have to submit to us to demonstrate compliance with parity in a standardized format. Up until now, we did have this documentation requirement as part of our regulations back from 2016, but what we found is that we get a lot of really complex narrative text and sometimes many hundreds of pages, and a lot of work to kind of sift through all of that information. States weren't clear on what they should be saying or providing to us. Staff, would struggle with some of this information to find the relevant pieces. So trying to standardize all of that information and streamline that review process, and really support also coordination of review of this information within CMCS, I should say, the Center for Medicaid and CHIP Services, because we have different divisions that oversee parity in managed care or alternative benefits plans or CHIP. So I want to improve our, kind of protocols and mechanisms for coordinating review. And really reduce time spent by states and plans on collecting and documenting, and want to improve efficiency and effectiveness of review to ensure compliance. So as I said, these are templates are out on Medicaid.gov. I will include a link to our request for comment. Comments are due December 2nd. We issued this in September 9th, but comments are due December 2nd. And we have a mailbox set up for that. And we also did a webinar to walk through the templates because they are fairly complex. So I will also provide a link to that webinar in case you really want to get into the weeds on that. So that's all I have. I'll turn it back over to David.
Great. Thanks so much, Kirsten. Really appreciate it. And, I just thinking about this from the broad scope of things, back when MAPIA was passed, ASPE did a lot of work to look at the impact of MAPIA on the marketplace. And they found that broadly, plans moved almost immediately into compliance with quantitative treatment limit requirements. So these were things that you could see very clearly in plan documents. So previously, plans may have charged discriminatory copays for mental health services, so a higher copayment or co-insurance for mental health services than they would for medical, surgical, or physical health services. And those were pretty clear, and that was the change we saw almost immediately. But the application of these non-quantitative treatment limits is much more complicated, and because it's much more complicated, it's much more opaque. And I like to point out the size of the job that the folks at the Department of Labor have. There's 2.5 million ERISA covered plans in the United States, and those cover 131 million people. And so the scope of their job of ensuring that those plans, a lot of those are smaller plans that aren't covered by MAPIA, but that they have to review those plans for compliance is huge, and especially when you think about the complexity of considering, what goes into these non-quantitative treatment limits. But the good news is that over the last few years, they've worked, the federal partners at Labor, HHS, and Treasury, along with other partners, have worked to implement MAPIA, have put out guidance. The laws have changed through several acts of Congress. There's more reporting about what's happening under MAPIA at the federal level. And with these additional final rules, really tightening the approach to non-quantitative treatment limits and really creating clearer standards for plans so that we're going to see less discrimination in these plans going forward, hopefully, related to these non-quantitative treatment limits, which really do impact access to care both directly through things like prior authorization requirements or authorization review requirements. And then I think also especially around network adequacy and inclusion of providers and networks, which I know
if you talk to anybody who's tried to find mental health services in this country in the last 2 years, they're all running into this issue. So this is hugely important, and it's very weedy. And I just want to thank the team members who participated in the presentation today, because and also just the half an hour of work you heard today is nothing compared to the just very detailed hard work that they've done over the past few years to really eke out a better approach to parity enforcement. So thanks to all of you. Oh, and there's some links, I think, being added to the chat if you're interested in learning a little bit more about what they presented on.
Yep, so this Anita Everett, and I there are several little comments in the chat, and at the risk of putting us behind a little bit in our agenda, I was wondering if we could have some of our speakers, and thank you very much for that presentation. Is a lot of dense information, but also very useful, the framing and the way you organize the remarks. So thank you. I was wondering if Beth or Kirsten, either one, could give us just a very high level view of plans for enforcement. There was some comment in the chat about difficulty with enforcement of the actual regulations, especially now that we have these new ones that'll be coming into play.
Sure. So I can start, and I think you know, David's remarks on the universe of plans and participants that they cover, that my agency EBSA has enforcement authority over under MAPIA is vast, and enforcement has been very difficult, especially because the non-quantitative treatment limitations, even though plans and issuers are now required to perform and document an analysis, what we found and talked about in the required reports to Congress that we've put out since the Consolidated Appropriations Act 2021 was enacted, is that those analyses, we haven't seen the level of detail or the thoroughness that we expect. And so it's a little hard to get sufficient comparative analyses to understand compliance with MAPIA, let alone, you know, to ensure that there is compliance with MAPIA. And I think the other thing that I would note is that EBSA is currently faced with some funding challenges. We had some supplemental appropriations that were temporary related to the Consolidated Appropriations Act 2021, which we've gotten a small technical extension on, but we do face a budget cliff in the very near future that will make it even more difficult to enforce. But it's definitely something that our agency is very focused on and committed to. We are also starting to work on updates to the MAPIA self-compliance tool to reflect the requirements of the 2024 final rules. So that is underway, and we do hope to issue additional guidance to help plans and issuers comply as quickly as we can as the rules begin to take effect, so that you know, there is as much information out there to help the entities comply that need to. The last thing I'll mention, because I know we're a little bit short on time, is that the Department of Labor Employee Benefit Security Administration has a staff of benefits advisors in our regional offices across the country that take questions and complaints and concerns from plan participants and beneficiaries. We've also heard from providers, particularly mental health and substance use disorder providers, so that if there is a problem with MAPIA, folks have a place to go, a toll-free phone number, or they can submit through a web form, and we have staff of folks who will call back and help people call their insurance department, insurance companies or plans, and try to get them the benefits that they're promised under the law. So I think those are some of the enforcement and compliance assistance things that we're thinking about as the rules, as we look forward to the rules taking effect and into the future.
And I'll just add that, you know, these templates are a first step in our improved and enhanced activities to improve compliance with parity in Medicaid and CHIP. As you may know, the Medicaid program is run as a kind of a partnership between the federal government and the state governments. You know, we have various ways that we engage with states in how they, you know, administer the program at the state level. One of those is through review and approval, required approval of their managed care contracts. So obviously that is a big opportunity that we will be and have issued guidance in June of this year. June 12th, we issued an informational bulletin in addition to this activity around the templates, just reminding states about their requirements and specifying and clarifying, our expectations and our plans to incorporate more reporting on parity compliance as part of the more of the regular and increasing accountability mechanisms we're putting in place around managed care. And then we are at the same time working with our alternative benefit oversight and CHIP oversight to make sure we're aligned and strengthening those mechanisms as well. Ultimately moving, we hope, to more of a outcomes-based approach where we identify where there are issues coming up, and then we can drill down and see what we received or what more information we may need from states to ensure there is compliance with parity.
Thanks. And I just would also want to recognize the great work happening at SIO with the marketplace plans, as well. So that's a whole section of this parity compliance work that is really important. And obviously a lot of people accessing care through those plans. And Jacob on our group is working very closely on that. So along with the rest of the federal partners on parity. Any other questions or discussion on parity? Or have you heard the word non-quantitative treatment limits too many times for one day already? All right, so we'll just be sympathetic for those folks because they hear it 80 times a day, every day. So.
No, thank you guys for that. And I'm really excited about just how all this ties together to the recommendations and the working group reports. And so I'm just going to give us the frame for the working group reports formats, and then Dr. Delphin Rittman will lead the group in those reports. So the stewards will lead an introduction to the working group. And then they will go over a review of the recommendations with a highlight of the key priority recommendations that they have been attending to, as we know that we cannot boil the ocean, but that they've really prioritized and gotten into the weeds on some of them, and more so than others. And made significant progress, as you can see just from this last presentation. There will be some triumphs. So what's some progress that's been made in the area of the working group, especially with respect to a specific recommendation, and then some discussion and voting. I'm generally just voting on the approval of the working group progress and reports. But I know that at least, for example, in the finance working group, there is at least one recommendation. There is one recommendation change that is being requested to be voted on by the group. So I will turn it over to the.
Great. Thank you so much, Dr. Shaw. And so we're going to go ahead and begin with Working Group 5, the Finance Group. And I'm going to turn the floor back over to David Dvorny and Michael Watterson, who will be joined at the end of their report by a guest from the Department of Justice. Dina Fox will join to discuss Olmstead updates. So David and Michael.
Great, thank you so much. We're going to try and move through things pretty quickly because I think parity, took a little bit longer than we were planning. I just want to welcome you, and Mike, I don't know if you want to say hi as well.
Yeah, I'll let you kind of take over, but just thanks for allowing me to be here and part of it. It's been pretty an amazing experience.
Yeah, great, thanks, Mike. All right, so just quickly to do introductions. Mike and I are fortunate to be co-stewards of the working group. You've already heard from several of our members on parity: Jacob Ackerman, Beth Baum, and Kirsten Baronio. We also have as a part of our group Mitchell Berger from SAMHSA, Dr. Abdul Ibrahim from SAMHSA, Noah Isserman from CMS, Jennifer Masudi from DOJ, Jenny Nate Cornelia from SAMHSA, Amber Rivers from the Department of Labor, Andrea Callow, hello, from ACL, Christopher Carroll, and then also Sean Turrell from ACL. And then we also have some non-federal members, of course, Brian Hepburn, Judge Stroud, and Catherine Warburton. Good to see you today in person, Judge Stroud, and everybody else online. So we've been meeting monthly, and we're happy to have a few updates today. The first is a vote that we're going to ask you to take during the voting section of our report out. And this is something we should have caught when we were doing updates to our recommendations, but we didn't notice because we weren't planning on changing this recommendation that we used some outdated language. I guess in the 2017 report, we had referred to substance abuse disorder services. And of course, that's stigmatizing in non-clinical language. We do not want to use it. And so we are proposing to make one small change, which is to change the word abuse to the word use in line with, I think, what is the right practice. And so small, I'm not sure how we missed it again. I apologize, but an important change. So that's what we're going to ask you to vote on. Otherwise, the recommendations remain the same. Next slide, please. Right. So we're going to talk about a few areas where we've made some gains, and these are our priority areas. So you just heard about parity. So we are working to fully enforce parity. We are looking at financing practices and policies that discriminate against people receiving behavioral health services. We are looking at payment for psychiatric and other behavioral health services. We're also trying to expand access to home and community-based services, as we'll talk about in a second. And then we're also working every day to expand access to care through certified community behavioral health clinics. Next slide, please. And I'm moving through these quickly because I want to make sure we have time for a guest speaker to talk. But I do want to take a little bit of time to brag. And some of this has already come up, but we have made a lot of progress in expanding the certified community behavioral health clinic initiative. As you have heard on previous calls and earlier today, the Bipartisan Safer Communities Act has enabled us to bring in 10 states to the CCBHC demonstration every 2 years, starting this past summer. So we were able to bring in 10 states this past year. We are also going to be awarding 15 new planning grants to bring in the next round of states in 2026, the end of this December. So just a little bit less than 2 months away. And so the progress continues. As Anita said this, or Dr. Ebbett said this morning, we're looking forward to bringing CCBHCs to every community in the country. The next area, this is our former co-steward, Dr. Sunny Patel, has moved on to different role at SAMHSA, leading some of our child and youth work. But before that, he was our co-steward, and he, during that time, helped to kick off the NASEM report that Dr. Everett reported on. And so we'd like to claim a small amount of credit for that work. It's obviously really important to improving care and the financing of care to have providers included in networks, especially in Medicare, Medicaid, and in the marketplace plans that are so important to people who are vulnerable and need access to services. I think there was one more thing we wanted to brag about before we switch slides. So that is, we are very excited because we have, in the area of expanding home and basic community-based services, undertaken a study of supported employment and looking at specifically how supported employment can improve health and functional outcomes for individuals beyond just improving employment outcomes. We'd like to make the argument that these interventions are important not only to boost employment outcomes, but they are actually core health services. And I think making that argument and gathering the evidence in that area will be important to having supported employment services be covered as a part of health services more broadly. And so that's something that's under development. We do have a study underway being conducted by Westat under our Center for Finance Reform and Innovation. That's a new development from our last meeting. And so something we're looking forward to progress on. With that, I do want to welcome our next guest speaker, Dina Fox from the Department of Justice. Dina is a leader in the Olmstead section of the Civil Rights Division at the Department of Justice. Their team really, as you know, I think is in charge of implementing Olmstead. And it is these Olmstead cases and the threat of Olmstead cases that often drive states to build out their comprehensive community services for individuals with serious mental illness and youth with SED. So with that, I'm going to turn it over to Dina. And Dina, again, thank you so much. Really appreciate you being here.
Thank you for including us. We're really excited to be here. And of course, our team is represented on the Finance Committee, and we really appreciate their participation and ability to have a part in the conversation about all of these important issues. So to give a little background for those of you who don't know about the different roles that the Civil Rights Division can play in this area, I will start with a quick introduction and then tell you about two examples of cases that we have ongoing right now and draw out a couple of the themes that relate to financing of services in this area for discussion with the broader group. So the Civil Rights Division can do a few different things related to these areas. First, we can conduct investigations and seek remedies to address alleged unconstitutional conditions in facilities, institutions that are operated by or on behalf of state and local governments. So that is under a statute called CRIPA, and in that statute permits us to investigate, for example, if there are violations of people's constitutional rights in a psychiatric hospital, for example, run by a state. But we also can enforce Title II of the Americans with Disabilities Act, and in particular, the Olmstead decision and the integration mandate within the Americans with Disabilities Act, which requires that states and local governments serve people with disabilities in the most integrated setting appropriate to their needs. So through that obligation, we have investigated and sought remedies for, reached agreements with, and conducted litigation against jurisdictions all around the country. There are three parts of the Civil Rights Division that do that work. The Special Litigation Section, which is the section that I work in, the Disability Rights Section, which is the section that has primary enforcement for the ADA overall, and the Educational Opportunities Section, which also enforces the Olmstead requirements as it relates to children and schools. So I'm going to give a couple of examples of cases that I work on currently that address the adult mental health system and the children's mental health system, just to give a sense of the issues that we see emerging in states around the country. I'm going to speak about Nevada and Missouri. These are both states where we have released findings about the systems, and we are working to hopefully reach agreements to resolve these issues short of contested litigation. And I'm going to post links right now to the findings letters. So there's some really helpful details in those letters that you can absolutely take a look at after this conversation, as well as additional information about our program overall at the Civil Rights Division website. Let me start with Nevada. So Nevada is a case relating to children who were unnecessarily being hospitalized and placed in residential treatment facilities because they were not able to access the needed community-based mental health services. As a result, psychiatric hospitals became the primary source of behavioral health services for children, and they also became a gateway to the longer-term residential placements of children. Many times placements out of state, away from home, many months at a time. Placement in these facilities resulted in sometimes stays away from family for over a year and many states away in some instances. The children also often experience repeated admissions to hospitals and residential facilities. And often when they returned home from a long residential stay, they were not then connected with the services that they would need to avoid a future stay in a hospital or a residential service provider. We know, and everyone at this table and around the Zoom knows, that there are many community-based mental health services that can prevent these out-of-home placements. Services like wraparound services, mobile crisis services, intensive care coordination, intensive in-home services, respite care, behavioral supports, and peer support. And luckily, Nevada's Medicaid plan does include many of these services, and EPSDT also provides a strong support for providing any service that would be medically necessary for these children. So there is a framework in place that will support preventing the unnecessary institutionalization. However, what we found in practice is that they were not necessarily available in all parts of the state, that the provider network was not sufficiently robust, going back to the parity conversation that you just had. In many places, there might not be anyone who could provide the service, or there would be a long wait list for accessing a service like wraparound or peer support, in-home services. They also might not be available in the level of intensity that would be needed. So you might be receiving 1 hour of an in-home service at a point where your family is in crisis and will not be able to prevent the hospitalization with that level of support. The issue had been well known across the state, and providers and local groups had created reports about this issue and presented them to the state for a number of years, but unfortunately had not been resolved. And there was just really not that necessary network of services to meet the needs of kids, nor was there the connection of the kids at those moments of crisis or at the moment of referral to a residential setting or return home from a residential setting to connect people to the services that they would need in order to actually move out of the cycle of hospitalizations and residential placement. So what we are hoping to accomplish with an agreement, if we're able to reach one with the state, will be to address those underlying issues in the community-based mental health service system to enable kids to avoid those placements. And I'll share a little bit about the Missouri findings that we released, and then open the floor to conversation about some of the themes that we've seen emerge, not just in these cases, but in other investigations and implementation of agreements that we've had around the country. So in Missouri, where we recently released findings, we found that thousands of adults with serious mental illness are unnecessarily confined in nursing facilities. About half of them are under 65. About half are concentrated in really high volume facilities, nursing facilities where more than 50% of the population are people with serious mental illness. They often remain for years in the facilities. And again, these facilities have those same indicia of institutionalization that we see in other kinds of settings: lack of choice in their day, lack of choice of roommates, what you eat, ability to leave, etc. The nursing facilities, like the hospitalizations in Nevada, in Missouri, the nursing facility placements have become essentially a default for people who've had a history of hospitalizations or who have not been compliant with treatment options that they've been offered. And oftentimes people are placed under guardianship in that circumstance, and then the guardians have few options of what services to provide for the same kinds of reasons that we were just discussing. And then they turn to nursing facilities as a simple solution to the service needs of the individuals who are under their guardianship, though the facilities are not actually providing mental health services to those individuals. The state has implemented the CCBHC model, which presents an opportunity in terms of implementation. However, what we found is that access to key services like assertive community treatment, supported employment, mobile crisis stabilization, permanent supportive housing, peer support is not consistent across the state and often was not seen as an option for these individuals and was not offered to them. So for example, among the individuals that we identified in the hospitals, in the nursing facilities, very few had been connected with one of these key services in the 3 years before they entered the nursing facility. So it's not that they were provided with, for example, ACT, and that was not working for them, and then they were admitted to a nursing facility. They never had an opportunity to have these intensive community-based services. We found that 8 of the 333 adults who'd recently entered a nursing facility had received ACT services in the previous 3 years. Only 15 had received any kind of residential services out of those 333, and only 23 had received peer support services. So we're seeing that there are people who are identified as having really significant needs, and those people have not been connected with the intensive and effective community-based services that are available in theory in the community, and instead they are placed in nursing facilities as the solution to what the providers and guardians are seeing as a problem of lack of access to services. What we are, again, hoping to work with the state to reach an agreement to resolve this problem, and hoping to see that both there is greater and equitable access across the state to these important services, and also that people are being identified and connected to those services through assertive engagement, not, identifying someone as having been to a hospital, offering them case management, they turn it down, and then they get placed in a nursing facility. There needs to be work to engage people in an ongoing way, and then to help them access the services that will support them in the community and give them that kind of choice and opportunity to live an integrated life that we know is protected by the ADA. So some of the challenges that we've seen in actually getting the services that are identified, that states have implemented in some form to the people who need them, include one, making sure that those key services are being required by the state throughout the state. So making sure that all of the regional providers, if there's a CCBHC model or a CMHC model, that all of the regional providers are obligated to offer these key intensive services for the people who have the most significant needs. And then actually doing the work to think through how to make sure that the funding model works for people who are in rural settings. So what we hear oftentimes is that the funding for community-based services where providers are going out to people's homes doesn't work as well for settings where they are rural, where there are significant drive time that is not compensated time between visits at different people's homes. So things like ACT become more difficult in those contexts, and we need funding models that will support that. Similarly, crisis services, I know, has been a key topic for this group over the last couple of years. And again, funding models that support crisis services where not all of the people who call will necessarily be Medicaid enrolled is really a key issue that we've identified. And figuring out those seamless braiding of funding streams where we know that we aren't going to only be able to have a state relying on Medicaid dollars in order to offer that key service to the people in its population. Things like supported employment and supported housing, as well as crisis services, come to mind to that front. So with that, I know I've gone over, brought us to the end of our time, but I think that there was a question for discussion, and I'll turn it back to David.
Great, thanks so much, Dina. And I'm gonna look over to the main group facilitators to see how much time we have. I know we're a couple minutes past 11:55, so.
Thank you. Thank you for that. It was really distressful and interesting. Question, do you have an idea of how prevalent that issue is around the country, or does it seem to be isolated to the states that you're looking at?
We do, these are not isolated issues. We have multiple investigations in other states on each of those issues, or have reached settlements, court orders in other states on each of those issues. And we also have other matters that relate to adult care homes and to more traditional hospitalizations. So these, I would say, they're the populations of individuals who've struggled with traditional services and need these more intensive services in all states. there is still a need for greater work to connect those individuals to the services and to ensure that those higher intensity services are really available throughout the states, and that's a widespread concern.
Thank you.
Okay. All right, so we will go ahead. Thank you again for the presentation and for the discussion. We'll go ahead, barring any additional discussion, we'll go ahead with the vote for the working group. And so can we'll entertain a motion to accept the working group report. May I have a motion to accept the report?
I move that we accept the report. Jennifer Higgins.
Great, thank you. May I have a second? Great, thank you, Ron. Would all ISMIC members unmute, or if you're in the room, all in favor, say aye.
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 Awesome. Any nays? All right, the report has been accepted. So thank you so much to the working group. Oh, with one, okay. One follow-up.
There's one item to vote on.
Oh, yeah, one item to vote on. Yes, okay.
Yeah, okay, so I think we're voting to change the word abuse to the word use and the parity recommendation. So I don't know.
Yeah, so does everyone, so all in favor of the change from abuse to use in the parity recommendation? All in favor, say aye.
Aye.
Great. Any nays? All right, thank you. Thanks to the working group. All right, so we are going to continue on. Okay. We are going to continue. Which one? Oh, yeah, focus area. Yeah. Okay, so next we're going to hear from focus area 2. We'll hear the access and engagement working group. We have with us Tara Andrews and also Captain David Barry. And we're excited to hear about the working group's report out. So David and Tara, I'll turn the floor over to you.
Thank you, Dr. Delphine-Rittman. Good afternoon. I'm Tara Andrews, Special Assistant for the Center for Mental Health Services and the co-steward for the Access and Engagement Work Group. I'm joined today by co-steward and Director of the Division of Suicide Prevention and Community Supports, Captain David Barry. The Access and Engagement Work Group is essentially tasked with making it easier to get good care. And our work group is led by Captain Barry and myself. And if you want to go to the first slide, thank you. And includes 9 federal members that you can see here and 9 non-federal members. In the interest of time, I'm not going to read all of our names, but thank you all for being part of our Access and Engagement Work Group. And before we dive in, we can go to the next slide. Wanted to take a moment to welcome and introduce 2 of our new work group members, Dr. Anitra Warrior, a licensed psychologist, and Tay St. Amour, the director of the Youth Movement National. Thank you both for joining us. Next slide. Our work group has 10 recommendations. Those bolded, 2.1, 2.2, 2.6, and 2.8 have been identified by our group as priority recommendations. Our primary focus is increasing access to behavioral health services with a special emphasis on strengthening crisis service, expanding coverage of behavioral health services, including peer and family support specialist services, and looking for opportunities to address behavioral health workforce shortages. Since our last full ISMIC meeting, our work group decided to add recommendation 2.6, prioritizing early identification and intervention for children, youth, and young adults, or to our short list of priority recommendations. Now I'll turn it over to Captain Barry to kick off the Access and Engagement Work Group updates. David?
So just to follow on what I presented with earlier today, when we talked about the NSSP, there is a lot of resonance between the NSSP and the ISMIC Access Working Group. So, we look at a triumph, and I think we're on the next page. So if we look at a triumph for the NSSP, for the nation is the NSSP. I mean, really, it is and I won't go into the NSP, but it is a large movement in the right direction for us modernizing and placing greater emphasis on suicide prevention, especially for those that are disproportionately affected by suicide and loved ones who have experienced suicide or suicide attempts or have successfully completed suicide. So the primary focus is NSSP is on suicide, but as I was mentioning, 2.1 and 2.2 of our ISMIC recommendations, which focus on finding and implementing a national standard for crisis care and building upon momentum and investments and growing and transforming behavioral health care crisis systems through partnerships at all levels, really does align with the NSSP. So the NSSP has, and like I said, for sake of time, we didn't go through all the things here, and this is something that I would want to leave up for discussion, is that there are objectives and goals in the Federal Action Working Plan for us to promote effective community engagement for risk of suicide during healthcare transitions between levels of behavioral health care. This is directly related to 2.1 and our crisis work. It's also the supported expanding 988 systems and related activities across the crisis care continuum, and to include mobile crisis care systems. So these are things that we could be, as a work group, really looking into and delving into as elements of the ISMIC as well, and seeing where the synergies between the two overlap. We also have a mobile crisis grant program within SAMHSA that would be something that we would include as part of this review, looking at suicide prevention and a comprehensive look at the crisis care system. So that's something that I would table for now, but we could think about as part of our discussion when we get to that shortly. Next slide, please. So another triumph is 988. I mean, 988 has continued to be incredibly successful. It is something that has been really a huge support for families and support and saving lives. Recent successes of 988. I mean, during Suicide Prevention Month, we had a 988 day, which really highlighted 988, and there was a partner toolkit. There was social media, videos, print. I think the vice president also retweeted some 988 day elements. So it is a huge triumph for us to be able to be doing that. As was mentioned before, you know, we kind of try to keep chipping away at suicide and helping those that are in crises, and this is was a step in that direction. Next slide, please. So 2.4 has not been one of the emphases of what has been going on in regards to the access, but it's worth mentioning because there has been some updates in regards to civil commitment. And I thought that, you know, just not necessarily a discussion, but something at least to bring to everybody's attention is that ASPE this summer released an evaluation on assisted outpatient treatment grant program for individuals with serious mental illness. It showed, generally speaking, that AOT is associated with improvements with treatment adherence, clinical functioning, and social outcomes. The evaluation also suggests that against the comparison group that was underpowered, that AOT involvement led to increased treatment engagement in comparison to other groups. So this is something that we have not spent focus on, but I think it's something at least noting because it is part of the recommendations for the access group. And we could ask ASPE if individuals are so inclined to provide a little meeting here and go over what the ASPE report says. That would be Joel right here, who's could be available for that, but that's something that we could talk about afterwards. But really, if you're interested in civil commitment or AOT and the strides that have been made for this specific effort, I recommend taking a look at the ASPE report, which can be found online. And next slide, I'll turn it back over to you, Tara.
Thank you, David. So priority recommendation 2.6, we've also had some recent triumphs. That priority is prioritizing early identification and intervention for children, youth, and young adults. And since our last meeting, SAMHSA launched the National Training and Technical Assistance Center for Early Serious Mental Illness, known as ESMI TTA Center. And that center was developed to foster recovery-oriented early intervention programming for individuals who experience early serious mental illness. On October 15th, the center kicked off a 12 series webinar session that will address topics related to early serious mental illness, including clinical high risk for psychosis and first episode psychosis. And more of those webinars are going to be released shortly. The webinar series is designed for a broad audience, including state mental health authorities, practitioners, providers, peers, family members, individuals experiencing early serious mental illness, and other stakeholders. In August, SAMHSA also released a brochure on early recognition and effective treatment of early serious mental illness, and this resource emphasizes the importance of early detection and intervention in serious mental illness, and the need for prompt attention at the first onset of symptoms, and the importance of youth and family engagement in early intervention services and supports. Next slide. And as Dr. Delphin Rittman and Dr. Everett mentioned in their remarks, there's been a lot of work on workforce since our last meeting in March. And in relation to recommendation 2.8 to maximize capacity of behavioral health workforce, on July 9th and 10th, SAMHSA's Office of Behavioral Health Equity hosted Embedding Equity and Building the Suicide Prevention Workforce for Underserved Communities Technical Expert Panel. The goal of this panel was twofold: to identify gaps and opportunities for embedding equity in suicide prevention, and to build the suicide prevention workforce to reverse the current suicide rate in under-resourced communities. The meeting was a follow-up to the NSSP that you've already heard about, and was specifically focused on strategic direction number 4, goals 12, 13, 14, and 15 of the strategy. Over 90 behavioral health experts, including a member of our work group, Dr. Stephen O'Connor from NIMH, participated. And one immediate outcome of the meeting was the dissemination of 5 newly developed population-specific suicide prevention resource guides from SAMHSA's funded centers of excellence, and those are listed there. Next slide. Oh, sorry, actually not next slide. Sorry, pause there for me, Joel. Other advancements related to the recommendation 2.8 includes the completion of several projects by the Behavioral Health Workforce Research Center at UNC. This is jointly funded by SAMHSA and HRSA, and the Research Center supports and disseminates rigorous research that strengthens evidence-based policy and enhances the understanding of issues and trends in the behavioral health workforce. Over the last 2 years, the center's completed 18 projects, several of which provided research to work that's related to the Access Engagement Work Group. A few projects include exploring the pipeline to graduate social work education, the behavioral health providers located, or question, are behavioral health providers located in areas of deprivation, preparing and retaining behavioral health workforce in safety net clinics, and how educational experiences relate to work satisfaction and retention, access and adequacy of peer support training, and provide to those providing mental health and substance use services. All of these resources are available to the public on UNC's Behavioral Health Workforce Research Center's website. And in year 3, the center plans to complete 8 more projects. 2 of those projects focus on payment as a critical aspect of workforce, and will build upon recommendation 6 of the NASEM report that we've already heard about today. Next slide. So as Dr. Everett explained, the National Academies of Science, Engineering, and Medicine's committee was asked to examine the current challenges in ensuring broad access to high-quality behavioral health care services through Medicaid, Medicare marketplace plans, and propose strategies to address these challenges. The committee specifically focused on proposing strategies to increase participation in behavioral health workforce in Medicaid, Medicare, and marketplace plans in order to ensure adequate capacity and access to care amongst increasing demands. The result were 9 broad recommendations summarized here and 31 more detailed recommendations. And in developing these recommendations, the committee was asked to focus on current perceptions and experiences among behavioral health care professionals and trainees, the current administrative and process barriers or policy barriers that produce a perceived burden, an actual or perceived burden, excuse me, and infrastructure requirements. So as you can see, these recommendations span many areas and serve as a blueprint for increasing behavioral health provider participation and in turn increasing access to beneficiaries. So these are all things we'd like you to keep in mind as, paths forward for our Access and Engagement Work Group. And with that in mind, I'll turn that back over to David to facilitate our discussion. Thank you.
So the couple of things that we wanted to. Yeah, so so the few things that we just wanted to address, and I know we have maybe a scant 10 minutes left. But with the release of the NSSP, and in light of the recommendations for the ISMIC that focus on crisis care, and there are implications not only for that, but throughout the NSSP, there's implications for access to quality care, equity in care, and other elements that are very meaningful to the Access Work Group. So we wanted to have that initial discussion here to see what the ISMIC members would like us to do in regards to the NSSP, and how detailed would you like us to and address the synergies between the NSSP and the ISMIC. We also wanted to talk about if there was interest with the ISMIC exploring the NASEM report recommendations related to access to behavioral health and the enhancement of behavioral health workforce, and also again to see what can we reap from the NASEM report to be able to enhance what we are doing with the ISMIC. So those are the two questions that we would like to pose to the ISMIC as a whole.
Question? Thank you. I think it's great that you added the 2.6. I think that's incredibly important on the early identification. But my question about that, does that also include early identification of trauma and intervening if trauma is identified? And if not, would you consider maybe adding a little language about trauma to that piece?
Yes.
To my knowledge, that doesn't specifically focus on trauma, but I think that that's an important element that we should be taking into consideration, and something we can certainly look into and explore in relation to the new Technical Assistance Center.
Can I make a friendly amendment then that we just add including trauma to the 2.6? I mean, we know, I'm in the criminal justice side, about 92% of the women and 75% of the men, those are SAMHSA data points, that end up in the criminal justice system have horrific histories of trauma. And I think if we identified it earlier and intervened and treated, we would keep a whole generation of people out of our system.
And I think that's something that, maybe we haven't explicitly stated here. And I think, to your point, that's very much worth tracking and including. But I do know that there are other efforts out there that do include trauma. So the Suicide Prevention Resource Center, for example, does recognize that as a precursor or a risk factor for serious behaviors that may be towards or untowards the individual. So it's something that is addressed elsewhere, but I think it's worth tracking in regards to.
Would you like me to make a formal motion? I'd like to make a formal motion then that we include just some language that include trauma to 2.6.
Before we make that formal announcement, I would caution us to move forward quickly on things that haven't been able to process. There's a lot of language changes that I think we would all like to see, right? What happens before trauma is environmental factors. That's not in there either. And so I appreciate it around trauma, and certainly like your prerogative to put that towards a vote. But if we are going to start getting into nuances of language and what is listed, I think we need to aim to process that and to be trauma informed in even our approach to then changing nuance and complex language.
I'm just asking for a broad, not that specific, just that we include it as something that would include trauma informed and all those other issues.
Did you want to include trauma informed as well as other risk factors or some language like that?
That would be fine.
Perhaps the working group, maybe would you propose that the working group in between the next two meetings draft a modification to the recommendation in that period, and then this process could happen, and then there could be a formal language to come back?
That would be fine.
Mm-hmm.
So just to clarify, we'll have something for March, or is that something okay.
I'll make that as a recommendation. I'll amend my recommendation. Thank you.
Thank you.
And so can I get a motion to accept that recommendation around developing some language for the next meeting related to incorporating trauma and other risk factors?
I'll make the motion.
Thank you. Can I get a second?
I'll second.
Second. All in favor, say aye.
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 Any nays?
Aye.
Okay, so the recommendation is accepted, and the team will work on additional language there. Thank you. Any other discussion?
Hi, I'm Joel Dubinitz. Lost my name tag in the process. I worked on the core group, project management group for the suicide prevention strategy. And I just wanted to pitch this idea of number one, because we really fully intended for this particular strategy to inspire action and steps by many other entities, including states, tribes, all the way down to localities. But we would be very happy if and I don't think it needs to be done today, but if people wanted to think about how it would be possible to connect some of the ISMIC goals. We certainly reviewed every existing document we could to make sure that we could harmonize projects. But I just wanted to encourage, and again, not necessarily right now, but because it probably takes some looking through some of the recommendations and then SP, but just to encourage that idea, I think it's really a great one.
Probably obvious to this group, but just in case, just to connect the dots, the individuals with SCD and SMI are at very high risk for dying by suicide. So that's sort of the connect there and why we're bringing up NSSP in the context of the SMI ISMIC.
Yeah, I think it's a great idea. The National Action Alliance for Suicide Prevention, who's home to a lot of that work, is actually launching a new task force on crisis care that Jill Mays and I are co-leading out of the Samson 988 office. But just, we're talking triumphs and talking about this interplay with crisis and suicide. I was doing a podcast recently and I asked ChatGPT on the 7 most significant developments in mental health since the 1960s. And stunned to see 988 is number 4. And I was like, deinstitutionalization, the Americans with Disabilities Act, how can you 2 years in put 988 in? I think it's fair to start thinking that way of the potential of moving forward. I just mentioned a couple of things as we talk about the triumph of what SAMHSA is leading right now around this. When I started with the National Suicide Prevention Lifeline Steering Committee 15 years ago, there were really 3 lanes for people outreaching for crisis care. And the Lifeline was only about 10% of that volume nationally. Most volume was, 40% of that volume was on your local county or state crisis line, but 50% was on 911 or people going to hospitals directly. And we are seeing a massive migration over to 988 already. It's shifting everything. You're seeing presentations at CrisisCon around the higher acuity that's already coming over. So this is an enormously transformative event. The migration of what historically was the scope of that lifeline for suicide prevention as SAMHSA's own mental health, but substance use and even IDD discussions that are going on around this. And the plan and the scale and the work you're seeing in local communities with mobile crisis and crisis facilities. This is, and then these opportunities to integrate with states. So I think there is a humongous opportunity there. We have tended to be a kind of a boutique thing at the end of the day, a lot of inside baseball. And this 988 day, we're just blowing the doors off of this thing now. And so the opportunity as we move forward is really at a level we've never, ever thought about. And the integration and coordination that comes it's the same thing that happened with 911. Hundreds of lines, and suddenly everything's being consolidated around a single number. So the opportunities both from operational impact as well as the stigmas and discrimination that we have in a society, we're hitting both with this dual. It's really tremendous. So the work Richard McKeon and SAMHSA and others have done to get crisis care into the national strategy starting in 2012 and really moving it forward with this latest version, I think is a great idea.
I know I'm a member of this working committee and appreciate a lot of the sentiments that have been shared. Triumphs are so important to celebrate and talk about. I would like to just mention the growth areas that we certainly have, right? Because when we're talking about these triumphs and how to implement recommendations and webinars, folks are still literally dying, right? I mean, CDC just came out and said 1 in 4 transgender youth are attempting suicide. So like people are literally losing our lives as we focus on these triumphs. And I just wonder if we are talking about trauma, right, and environmental factors, the things that sort of come before suicide. I just think we have so much more to do when it comes to the over 530 anti-youth queer and trans bills that are making its way through states. You know, my tribal nation is in Texas, and when we talk about clinicians and mobile crisis response, you know, police are coming out to households that have queer and trans youth and essentially arresting them because they're going against state laws. So, you know, it feels like we've got a fire hose aimed at our queer and trans youth, and we're really just trying to prevent them from getting wet. And they should not get wet, but we also have to focus on the fire hose because there are systemic issues that are not being addressed. And so often when we talk about funding to states and these block grants, I think there can be more to do to really start to focus on what some of these systemic factors are and try to focus on those initiatives.
Thank you for that. I mean, I think that's right on, and definitely, you know, there's more work that we know we need to do, and appreciate you raising those areas where there's additional work to be done. So, and I know that the work group leads are leading the discussion, but I just wanted to jump in there. But we'll turn it back over to the stewards.
So I think we're hearing what you're saying. So I think for a couple things, we could be looking at, you know, that broader trauma-informed element in the language. We could include a 2.6, but also, you know, being mindful about the environmental factors. And I think this is something that, you know, when we have our next access work group meeting, we will be bringing this up, and I imagine we would have a robust discussion around this specific raise of recommendation. And I think what you brought up, Tay, in regards to thinking about, you know, yeah, we focus a lot on the triumphs, but we have a long way to go. And I think there are elements we could do that. And I think, you know, when we go back to the NSSP and having those elements, and as Dr. Ever, you know, linked the NSSP stronger to the ISMIC here, I think there's elements that we could be thinking about where we could have those rooms for improvement and how we can be doing that. Because when we think about the fourth pillar that's in the NSSP, focusing on those that are disproportionately affected, you know, I think that's where we have a lot of work, and we could be talking about that not only just from the ISMIC perspective, but from the NSSP perspective and from the NASEM report in regards to tying all these things together. So I think as we move forward as a work group and we have our next meeting, I see that from this discussion today, we have a lot of robust work that we could discuss and things we go forward from there.
I'll just note that as I'm looking through the recommendations for 2, that there is not any equity specific element of these recommendations. And that was a key point of what you mentioned, Tay. So that's just something to think about as you guys think about.
And that's, you know, when we talk about adopting language, that's something we may want to bring up in March.
And it's the way we've structured the result of, you know, the process. If you wanted to make, you know, the committee wants to proffer an additional recommendation, that this group could vote on it. So
that's
on equity in particular, or something like that, if we feel like these don't address that.
Thank you. That's an excellent point.
So one way to push both the equity comments that Tay referenced, explicitly calling out, we still, this issue of psychiatric boarding and law enforcement involvement for someone who is not a threat to public safety, is not involved in explicit criminal activity, does not have a physical health medical emergency. And yet every day we're talking tens of thousands of people who are engaged in those systems. So 988 provides this opportunity, Tay, but it's just a stage, right? We got to build it out on that stage. But calling out unnecessary law enforcement involvement, which is a win for everybody. It's a win for law enforcement. It's a win for the public. Unnecessary hospital medical department involvement. Again, we're talking about what we're going to do, but why are we doing it, or what we're not going to do? It's calling that out as well as another way to get there. Ron, we were talking about that on the way in.
So we are in your lunch break right now. So I don't know. I mean, I think this is something we could actually like literally spend the rest of the day talking about because it's that important. But I want to be mindful of grumbling tummies. So, so I would like to, see what about, I think we have some guidance going forward. And I think we would turn it back over to you, Dr. Delphi Rittman, to see about anything else you wanted to close out for the Access Work Group.
Can I make one last comment? I'm sorry.
Yes,
I don't want
go
to hold everybody up. I'm hungry too, but Dr. Warburton and Dr. Vincent and I, just this day or two, returned from Trieste, Italy, where we were part of a group that was studying the Trieste mental health system. And it was remarkable. And I get a little concerned that we're very focused on pieces of a problem as opposed to looking at the larger system in general. And what we found, and I'm sure Dr. Vincent or Dr. Warburton may want to add in, a lot of the things that we're trying to address don't exist because they have such a better system. They have very few civil commitments because people are in a system where they're in a recovery model that is constantly being addressed. You have a continuity of care, you have housing. They do not have many, if any, people with serious mental illnesses in the criminal justice system. They do not have a competency restoration problem because people are in care. The doctor, that is in this catchment area is responsible for all the patients. And he goes to people's homes, he goes to the jail, he goes to the hospital, and there's a full coordination of care. And so people are integrated into the community and they're not judged by their illness. They're just people who live in the community. And it is really phenomenal. Is it perfect? No. Compared to us, yes. And they still have some places to go, I imagine. But it is something that we need to try to think about when we're putting all this together. And I think this work group is probably the closest to any of our work groups. But it's really about developing a model as opposed to just addressing pieces of the problem. And I don't know how to give you language for that. I'm happy to try because we just got back. I just got back last night. It really is different. And it's something we should all aspire to put into place. And I just worry sometimes that just trying to fix the pieces and not the whole doesn't get us where we want to go. So thank you for that.
Thank you. Yeah, I mean, really important points. I'm familiar with the model and the piece that always struck me is the ways in which people with lived experience run like recovery, I believe like the recovery cafes. And it really is sort of person first and people have valued roles, valued sort of important, meaningful roles right out of the gate. And so it's this really it's an amazing model. It's
And they don't wait for you to get so sick that we have to, involuntarily commit, or you've been on the street for 20 years. There's like no homeless people with mental illnesses there.
Yeah.
And it was really remarkable to see. And it's a mindset, it's a cultural shift, but it's the right one. And a lot of lessons to be learned from what they're doing.
Great.
Thank you.
Thank you. So we do need to go ahead and approve the report with the recommendations that we already voted on. So can I get a motion to approve the working group's report with those recommendations that we voted on? So can I get a motion? Okay.
So moved.
Great. Second?
Second.
Fantastic. All in favor, say aye.
Aye.
Aye. Any nays? All right, we're good. Thank you. So I'm going to turn it over to Dr. Shaw, who's going to go over sort of next steps and lunch and timing and all that.
So the photographer is back with a whole ladder and everything to take a picture of the group in the atrium. And then right from the atrium, go to lunch. And if we're looking at the time, let's say 12:30, let's extend by 5 minutes, just be 5 minutes off. I'm sorry, 1:30, return at 1:30, thank you. And
we're going to go ahead and some treats for the afternoon. So there's a bowl of candy going around. So it's coming around. I will say for the record, my favorite are the peanut M&Ms. Are those not the best? I know. I'm hoping there's one left when it comes around. You know what? It's all good. Oh, no. See, I have some right here. So, okay. All right. So I hope everyone had a great lunch. And thanks everyone online for coming back as well. Okay, so next we're excited to hear from work group 3. This is a treatment and recovery work group. We'll be hearing from Doug Sloffer and Nancy Kelly. And so happy to turn it over to Doug and Nancy.
Good afternoon. Thank you. This is treatment and recovery work group 3 post-lunch presentation. So next slide, please. So this working group is treatment and recovery. The stewards are Nancy Kelly and myself, and we have an all-star team of federal members, including Mina Vithilingham, Richard Davis, Rhonda Basha, Sandy Resnick, Susan Azrin, Corey Miner-Smith, Yolanda Luzon, and Marcia Hunt, as well as non-federal members David Covington, Rathelia Stroud, and Amanda Lip. So we appreciate all of them, and it's really been a great group to work with. So next slide, please. So these are the recommendations that were in the ISMIC report to Congress. And if you look at them, there's 10. They really are extremely comprehensive. They pretty much encompass the whole of mental health treatment and services. So when this group was kind of re-energized and we looked at where to focus our energies, we really had to think about how to cut this down in a way and focus it that would really make it manageable. And so what we did, next slide, please, was to choose the principle of focusing on promoting evidence-based practices that were assessed as both having a strong evidence base, but also being underused, and really identified this as a way that we could sort of bring to bear the resources of federal collaboration in a way that could hopefully make an impact on highlighting these and bringing them into wider implementation. So of those, the 3 that were chosen for the group were supported employment, supportive housing, and early serious mental illness, including the first episode of psychosis treatment. Next slide, please. So our triumphs, we have some for each. In the supported employment area, you may recall from our previous meetings last year that a policy academy for states was held on supported employment. And in the past year, a year-long learning community was held for those policy academy attendees to allow them to really build on that academy and implement and share lessons learned and things like that. A new policy academy was also held on the provision of supported employment through CCBHCs. A guide on coordinating and leveraging resources to increase supported employment was also developed under the Aspire initiative and released. So again, I just want to emphasize, like, these were really true interfederal efforts. The policy academy, the policy academies involving SAMHSA, Department of Labor, multiple participants. Then in supportive housing, it was really a very busy year in the space of housing and homelessness and housing support. Strong interagency efforts continued throughout the year, including the All Inside initiative, which is coordinated by USICH and includes HUD, SAMHSA, ACL, and many others. There was a year-long Housing Supportive Services Partnership Accelerator, including a convening at which many states were brought together, and a year-long learning collaborative for states selected by HUD to support ongoing implementation efforts coming out of lessons learned in that accelerator. And we are looking at another HISPA 2.0 for the coming year, continuing that work. Both of these have had a focus on supportive services and housing needs with interagency support, including ACL's Housing Services and Resource Center, which is again another sort of interagency collaborative effort. And then finally, SAMHSA is also working on or developing or updating multiple resources related to the intersection of SMI, SED, and homelessness. You know, I'd also add there's been a lot of congressional and White House interest in these issues. So a lot of sort of response around this, a lot of interagency response on those issues as well. And then finally, early serious mental illness. So, you know, this, the issue of early serious mental illness was chosen in part because, you know, Congress signaled its interest by, you know, revising the set aside in the mental health block grant from one specifically for first episode psychosis to one more broadly focused on early serious mental illness, because obviously not all serious mental illnesses include a psychosis component, and really signaled their intention that you know, these broader issues be addressed as well. And that's something that SAMHSA has taken up as well through the creation of this ESMI TTA Center, which again has includes first episode of psychosis and coordinated specialty care as a model, but more broadly is also looking at other serious mental illnesses, the onset, clinical high risk of psychosis, various aspects that all relate to this. And this Technical Assistance Center is providing direct TA to providers in communities. It's held technical expert panel meetings to identify and make recommendations on products to be developed. It is convening learning communities based on those recommendations and developing additional resources. So we're really seeing movement in all these areas, and especially, you know, sort of a federal consensus around the importance of these issues, and a lot of collaboration, which is the name of the game here for ISMIC. Next slide, please. So for our discussion, we generated 2 questions, one specific to the ESMI area. We know that first episode psychosis is well researched, and it has a well-supported treatment models through coordinated specialty care. Our question is, knowing that there's a need to look more broadly at ESMI more broadly, and, you know, looking at FEP and CSC as sort of a model, as a robust model of how that can be, you know, developed and implemented. How can we kind of do the same for other ESMIs? How can federal efforts identify and support innovative and best practices for the onset of all SMIs? Because we know there's not the same level at this moment in time of sort of developed models that are as well researched and so forth, but how can we sort of follow in that path that was blazed by FEP and CSC research and program development? And then the second question is really a very process-centric ISMIC question. How can federal ISMIC members work more effectively with non-federal members to create linkage and feedback between federal interagency initiatives and private systemic priorities and innovative development? Because, I mean, I'll say, like in the treatment and recovery work group, it feels more federal centric than I think our goal would be. We'd like to have it be more broadly collaborative and encompassing between federal collaboration, but also collaboration with private mental health work. And so how can we do some of that? How can we broaden that collaboration? So those are our questions, and we look forward to any thoughts or discussion.
I mean, maybe this is kind of obvious, but I feel like your second question's answering the first question, right? I mean, how to figure that out is to talk to them, right? I mean, going to peer supporters, going to direct folks with SMA without that psychosis, I think obviously community is going to be able to speak best for themselves. So I think that makes your second question far more important, right? Is how to do that work. And I think that there's folks like me at the table who I'm not a federal member that runs a youth-led and youth-driven organization that can help you with eliciting some of that feedback or knowing sort of peer support groups in which you can go for that. Separate to this, as I'm throwing a wrench in all of these question discussions today, just curious if we do have time, how did the SCOTUS grants pass ruling? How do you feel like that's going to affect your work as far as supportive housing?
Well, I mean, I would say it's not directly impacting our, the structure of our programs, which are, you know, not at odds with the ruling, but obviously that potentially has a big impact on what other systems might be doing in the community. And since our programs work collaboratively in communities, then, you know, obviously we're going to have to adapt to whatever developments may come out of that in terms of, you know, what community services, how they're approaching homeless services and what sort of laws, you know, they may pass or continue to implement around criminalization of sort of common activities that are inescapable from being without a home.
Totally. I mean, I think I would argue that folks related to SMIs have disproportionate rates of houselessness. And so if you are now criminalizing houselessness, the community orgs in which you're referring to are going to be at an overcapacity, which they already are. So that's the connection that I'm putting, that I think it will affect you in major ways because of that.
Appreciate that. Thank you.
All right. Any other questions or comments? Great. All right. Thank you so much, Doug and Nancy, for that report, and to the work group members for all the work in between our meetings. So we'll go ahead and entertain a motion to accept the working group report. Can I have a motion? Thank you. A second?
Second.
Thank you. And would all in favor say aye?
Aye.
Aye.
Any nays? All right, so the report is accepted, and thank you again to the work group.
Dr. Dolphin-Rittman?
Yeah.
We heard from the online folks
Oh.
that there was a concern that the photo was not inclusive of our virtual members, which is very valid.
Yeah.
So just in case we have some people that need to leave early or something, let's just like try to get a quick photo in with the virtual people, so they had no warning. But if they could get on camera, and then we're gonna try to take a picture of the entire room.
Yes.
Yes.
Yeah, that's important.
Photoshop.
We thought about that too.
Yeah.
You can also try to do a screenshot.
And thank you so much for the online folks that pointed that out. I mean, it's always we're still trying to like figure out the virtual hybrid. So that's an important thing to remember when we do photos, to definitely incorporate in the folks online. So appreciate that reminder on that.
So
Okay.
Stephen, what do you, however you think would be best? Oh yeah, let's try to do it in between the two.
Can we get the online folks on that screen?
Can we transfer them over there?
Oh, or actually if Stephen takes it from down there, but.
Take them down there.
That screen's the bigger one, but that may be complicated. Oh, no.
I have no idea.
How to get that one over there?
No, I think Selby, I think it's in process.
No, we can figure out how to make it.
Okay.
I don't know.
Okay.
Well, I think we know
that's
how to get
okay.
it on that one.
Yeah, no, thank you for trying.
So we can try with, we'll do one try with.
Because they'll be bigger, so we'll be able to see them
better.
I have no idea.
No, okay.
All right.
Okay, but this screen is a decent size, the other one. Okay.
Should I displace everybody next to the screen?
Oh, yeah, that's true. Yeah, no, that works too.
Let's do that.
Yeah, if we all gather around that screen. Yeah, yep, that end of the room.
Yeah, one quick photo, just.
So now the criminal justice. We're on the criminal justice work group. All right, so we're going to continue on. So next we're going to hear from Focus Area 4, Criminal Justice Working Group. And so we'll hear from Gregory Crawford and also Maya Banks, who were the stewards for that work group. So Gregory and Maya.
Awesome. Thank you so much, Dr. Delvin Redmond. And yay, we made the picture. Good afternoon, everyone. So I'm Maya Banks. I'm former co-steward for work group number 4. Here, of course, with my colleague, Gregory Crawford. And so our working group name is Criminal and Juvenile Justice Work Group, and our co-stewards, of course, Gregory Crawford, and also Commander Katie Hager. And so Commander Hager is the new co-steward of Work Group 4, effective October 1st. And we are super excited to have her with us in her new role. She had a long scheduled temporary duty assignment and is unable to join us today, so I'm filling in. And just real quick to note that Commander Hager is the chief of the Community Support Programs Branch, which houses several programs, including the Early Diversion Grant Program, as well as the Gain Center for Behavioral Health and Justice Transformation. So perfect fit. And again, we are super excited to have her with us. We want to recognize and appreciate our fantastic federal and non-federal work group members. So our federal members include Marielle Lifshitz, Marissa Farina Norris, Brooke Mount, Marcy Mistret, Sarah Russo, Dia Boutwell, Jamira Howard, Mary Taffy McCoy, Katie Stewart, Kirsten Jensen, Michael Tankersley with CMS, and from SAMHSA, of course, Joseph Bullock, Roxanne Castaneda, Leah Compton, Aaron Eduardo, Joel Fuentes, Karen Gentile, Tiffany Russell, and Linda Zeller. So just thank you all for being amazing. And of course, our non-federal members, Judge Rothelia Stroud from DeKalb County, Georgia, Judge Stephen Leifman with Miami-Dade, Florida, Trinidad Arguello with Compostela Community and Family Culture Institute, Ron Bruno, Crisis Response Programs, and Catherine Warburton, California Department of State Hospitals. So thank you again so much for being just amazing work group members and continuing to move this work forward. Our meeting frequency is every 2 months. Okay, and let's just talk. Oh, are there slides? I'm so sorry. Are we showing slides? Okay, I don't see them on my screen. Sorry about that. So in terms of recommendations, so the following recommendations support the use of diversion at all points of the sequential intercept model, or the SIM, to provide quality treatment and recovery supports. So I won't go over all of the 8 recommendations. Just note that we've had no changes in the recommendations. And just briefly, recommendations 4.1 address the need to prioritize diversion at all intercepts in the SIM in favor of trauma-informed, accessible, culturally and linguistically competent, and developmentally appropriate mental health treatment and recovery services for both adults and youth. And then we have 4.2, which addresses the need for federal agencies to continually analyze currently applicable and new federal legislation to identify opportunities and collaborate to address these issues at all points of the SIM. And 4.3 through 4.8 really address specific intercepts in the SIM, prioritizing again diversion and access to quality care throughout. And so I'm going to turn it over to Greg to discuss our priority recommendations, triumphs, and lead our group discussion. So Greg, turning it over to you.
All right, thank you, Maya. First of all, I apologize for not being in person with you. I'm actually in Seattle, Washington at the Police Treatment and Community Collaborative International Deflection and Early Diversion Summit. 2 of our working group members, Dr. Bullock and Katie Stewart, are also here. So I'm excited to present later this week about the front end of the system. But on to priority recommendations. The working group collectively decided not to prioritize particular recommendations because of the focus of the entire sequential intercept. However, recent discussions have involved 4.1, 4.3, 4.4, and 4.6. 4.1 is support interventions to correspond with all stages of justice system involvement and to consider all points of the sequential intercept model. 4.3 is to enhance diversion in crisis mental health services to divert people with serious mental illness, serious emotional disturbance, and co-occurring disorders from the justice system before arrest and at all stages of the SIM, and build the capacity of first responders to interact with this population in a de-escalating and trauma-informed manner. 4.4 is to establish and incentivize best practices for competency to stand trial that prioritize diversion from arrest or jail, juvenile detention for people with serious mental illness, serious emotional disturbance, and co-occurring disorders accused of committing low-level and non-violent offenses, and that use community-based evaluation and restoration services when CST efforts are necessary. And 4.6, encourage the use of universal screening for mental illnesses, substance use disorders, and other behavioral health needs of every person booked into jail, juvenile detention facilities, and diversionary community services, and provide assessment, treatment, and referrals when warranted. Next slide, please. Okay, so our triumphs. We did meet 3 times as a full working group since the last full ISMIC meeting in March. We continue to work collaboratively to develop a resource that highlights funding opportunities across all intercepts and helps guide communities on how to access these resources. We're pretty far along in that project, and I don't want to promise a timeline for release, but we are working on it, and it's been a very collaborative venture with our federal partners and group members here. So excited to share more about that probably at the next meeting. Supported Employment Policy Academy held for CCBHCs, and supported employment included sessions on critical aspects of addressing justice-involved individuals' employment challenges and support needs, including in employment as peer supports. Continue to research judicial training to identify gaps in our need for further investment to develop new resources for judges and court teams. To better work with individuals with serious mental illness, we've conducted a full environmental scan and literature review and working on a document as we speak. And then also continue to strengthen coordination and collaboration that ensures integration of criminal justice and SAMHSA-related products. Okay, so let's go to the next slide, please, and on to the group discussion. What is one way local, state, and federal partners can work collaboratively to improve outcomes for individuals with serious mental illness and/or substance use disorders and minimize arrest and/or justice system involvement? And the 3 areas we wanted to kind of spark some discussion around is the sequential intercept space 01, which includes community law enforcement and emergency services. Also crisis intervention services. Who are the stakeholders? And jail booking, screening, and assessment, and also, you know, how timely should that be, and you know, what services should be provided in custody and/or in reach. So I will leave it at that. Does anybody have any comments in this area? Is there anything this working group can do to help move those areas along in terms of evidence-based practices?
So it's kind of interesting that, you know, that this just came up. When I was at lunch, we were having a discussion about, you know, civil commitment. And when we look at serious mental illness, a lot of times, you know, we are dealing with an individual has no awareness, of course, that they have their illness. And they just seem to get further and further into the criminal justice system. In fact, while I was sitting here during this meeting, I got a text from somebody in my home state saying, you know, this has been a concern because her son basically ended up in jail, still is in jail, dealing with the criminal justice system, all because he was in a state of you know, psychosis. He really did not know what he was doing, and he, you know, damaged his own house and that kind of thing, turned into domestic, even though there was no domestic against his wife. But anyway, he got tied up in the criminal justice system strictly because of mental illness. And so when I look at this, and when you ask that question, what is one way local, state, and federal partners can work collaboratively to improve outcomes for individuals with serious mental illness and basically keep them out of the justice system? I think that is a big group in our society that have serious mental illness do not have that awareness, and they tie up into the criminal justice system. Judge Leifman was sharing some stories from Italy, and he said something, and I'm sure it would be very difficult to actually address it here in the United States, but I'm going to throw it out anyway. He said, over there, it is not based on danger. Civil commitment is not based on danger. It is based on need. And if we could just figure out how to base it on need and not on level of danger, think of how many more people we could actually divert from the criminal justice system, because they're doing things that's getting them involved criminally. They're committing crimes, but it's because of their mental illness. So it is actually kind of based on need. So that's the only thing I could think of at this very second, but I'll continue to think, since I work on this group, I'll continue to think and share with you.
Sounds good. Anybody else?
Yeah, one other point. I would recommend that maybe we take a look at the recently passed Conference of Chief Justices, Conference of State Court Administrators Task Force report on mental health. And in there, they adopted a recommendation from our task force that talked about establishing new pathways. And so when we have this idea that if somebody gets arrested, that they have to stay in the criminal justice system for treatment. That's really not the case. And so we created new pathways for individuals that are considered lower risk of criminal justice involvement, and maybe transferring those cases to a probate division and let them handle those cases. So the person is at less risk of getting a criminal record, because once you adjudicate somebody, it's harder for them to get employment, it's harder for them to get housing. And so maybe move some of these cases that are appropriate into the civil system. And I'll be happy to share the report if you don't have it and show you where that is in the report. And that was based on a foundation work group called Equitas that came up with all these new pathways. And it's really a pretty thoughtful approach to some of the criminal justice issues.
Yeah, please share it. That'd be great. Anybody else?
I think an area in your question in which I'm getting caught up in is the minimize arrest portion, because I think that obviously that's sort of it's like don't arrest them. And so I feel like just having more local, state, and federal work with your law enforcement and state agencies, uniformed officers, to avoid arrest in the first place. So talk about those trauma-informed de-escalation movements, plainclothes officers, peer support specialists showing up, a lot of the things we talked around what we want to see in MCR and our recommendations. I think that's another way you could do that, is just by not arresting them.
And if I may add, I think the movement, we were talking about this at lunch too, we really need more co-responder models so law enforcement isn't responding at all, and then leave it to the cases where there may be weapons or violence, or have them as backup, not primary. And, because there's another part of it. I mean, we have a great CIT. I have 8,600 officers in Miami, but standard operating procedures still require them to put handcuffs on the person in the backseat of a car. So you have an 18-year-old first episode who's humiliated because it looks like he's getting arrested when he's not. He hates his parents for life after that. And so if we had more of a emergency response like we do with heart attacks, I think it would help avoid lots of different situations. And I think maybe we should add a recommendation in our report about more co-responder type models and using law enforcement as secondary when appropriate.
I'm doing an emphatic +1 to that.
I want to add to that, to decriminalize mental illness. I preside over a misdemeanor mental health court, and diversion really helps, because with our court, once a participant completes our court, our Solicitor General actually restricts the record, so no employer, university, or mortgage company, or anybody like that gets to see that they were ever in the criminal justice system. And then she dismisses the charges with successful completion of our entire program that's certified by the state of Georgia. So diversion does help.
Mm-hmm. Well, I certainly agree with all of those comments. Mina, you have your hand up?
Yeah, this is a question for the legal experts. I was very intrigued by the point that you made, sir, about how the threshold for intervening is need and not, danger to self, others, or gravely impaired. What would it take to shift the law? That's number one. And how need gets into nuances of individual rights and needs, and how was that resolved in Trieste? Over.
It's very interesting in Trieste because very few cases actually end up going through civil commitment. They do such a great job at the front end. And I think we need to make sure we have both of those things so that people don't decompensate to the point where they need hospitalization. In the community, in the catchment area that we visited, they had 1,000 patients and only 10 in a year went for civil commitment. It's done very differently. 2 independent doctors file a petition. It does not go before a judge. It goes to the mayor because technically the mayor in Italy is considered responsible for the population. So he or she signs off. The court only makes sure that the actual application is adequate and doesn't rule on the actual piece. But I think you have to, combine it with a good community system so people don't necessarily need it, so it's used as a last resort. And the other thing, to your point, it has to be done state by state, which makes this much more challenging. I think the federal government could get involved if they wanted to by using financial incentives to have certain standards, but I doubt if they'd ever go there. It has passed constitutional muster to use a need for treatment criteria. I'd say the most closest to any state that has that, well, actually has it, it would be Michigan. They have a need for treatment and it's been upheld. And so you may want to take a look at that law if you're interested in having this kind of standard.
Thank you so much. That's very helpful. Thank you.
Sure.
Sue, you have your hand up?
Yes, yes, thank you. Observation from kind of the downstream from the conversation we're having and the importance of kind of figuring it out. I know a gentleman who's in his 60s who's been in his current employment 20-something years with a background check every 3 to 5 years is required. So all these years, the background check has been all right. And now the background check has come back unable to be employed in the job he's held for all these years because in an early childhood psychosis, he did some damage, property damage. And well, the notice that came from the state of Georgia was that he had to be terminated. And he's appealed, but they refused to say whether he can maintain his job. I give this example just to underscore how incredibly important the work you're doing now is. This is the rest of a man's life, and he's being told he can't be employed. So thank you very much, because I think it just really underscores, everybody in this committee and the work they're doing.
Thank you. Do we have any further comments?
Yep, Sarah?
So I'm a child psychiatrist by training and do community mental health work with kids. And just thinking about the issue of, local agencies and minimizing juvenile justice involvement. We talk a lot about the school to prison pipeline, but there's also an expulsion to prison pipeline. And as we are seeing a lot of kind of reactionary policies related to the substance use epidemic and to overdoses, zero tolerance policies in schools, just thinking about education around those things, the fact that these children are often self-medicating and not having those kinds of school policies that are going to feed youth into those systems.
So thank you. Yeah, this is Anita Everett. I was going to ask Judge Stroud if she has any sense about how common those laws are at the state level. So, and if we are executive branch employees, we can't
dictate law ourselves. But we can sometimes accumulate, like we could do a survey of states to find out how many other states had, that is something that sometimes makes other states aware of things that are useful one state to the next when we're kind of a hub of information. Would that kind of thing be useful, or what's your experience with other states?
Which law? Are you talking about what she just said in terms of that individual being disqualified now?
No, well, with the reverse of that, actually, I was talking about your law that allows low-level criminal records to be erased or hidden somehow so that they're not available for job search for certain purposes.
Every state, I'm sorry,
I'll speak when you finish. Go ahead. Go ahead. No, no, no. You're well versed. Go ahead. Well, in terms of Georgia, we do have a program. We actually, accountability courts is what affords us this opportunity. And they have been codified in the state of Georgia by our last couple of governors. So it is, in fact, law that allows this to happen on for misdemeanor courts and some very, very minimum felonies. So it's, I don't know where else it is. And I tell you where we could look, and in terms of just kind of getting an idea, is with All Rise, because they actually teach and train in terms of accountability courts. So I think, I'm sure Georgia is not the only place. I'm sure it's throughout. And Judge Leichman, I don't know if Florida, I don't know if your courts did that. Were you able to restrict or records? Because that's exactly what happens with our court. And the great thing about it is that when they complete our program, our Assistant Solicitor General is there in court to give them that restriction where their offices actually follow through with it. So it's not seen by potential employers or anybody.
So every state already has laws on the book that allow for diversion.
Yes.
Doesn't have to be for mental health. Theft, you name it, first-time offenders. So most of us travel under those existing laws. And then what often happens is you'll have a collaborative agreement within a particular circuit. So for us in Miami-Dade, if you successfully complete the program, we drop the charges entirely and we'll seal the record. And we do it both for felonies and for misdemeanors. One thing to be cognizant of that I don't like is a lot of states, a lot of courts may require the person to take a plea before they get into a program, which I think is horrifying. And then what they'll do is if you successfully complete it, they'll vacate it and dismiss it, but it puts you at a much higher risk. And it also sends a terrible message that you have to plead guilty to get treatment, which you shouldn't have to do. Our system works the opposite way. It's all voluntary. If you want to leave and go get tried, that's fine too, at any stage. But no one ever does because we're dropping the charges at the end of the day. The other thing that helps us do is avoids competency evaluations because we're not pursuing charges. There's no constitutional requirement that you have to get evaluated for restoration. So we've been able to significantly reduce the burden in that area as well. And if you want us to pursue this, we could add more recommendations in this arena. I'm on that committee and I'm happy to do that. But certainly it works if you do it right.
Yeah, but I'm happy to say that with our program, with our court, there is no plea. We're pre-plea. So there is no plea. There is nothing on the record prior to them entering our court. They just have to voluntarily agree and they have to have the cognitive capacity to do that because we require certain things that we have groups that we have for them, available for them. They have to have a day structure, whether it's a job or school or something of that nature, and they have to be with us a year. Our standards are codified and certified by the state of Georgia in order for us to get money for them to fund our groups. So that's how we operate.
I mean, I like the idea of maybe additional recommendations here. I think even just in that discussion, so many areas came up that I think even an environmental scan around like what does it look like at the state or even county level with respect to record expungement? And I know there's different terms used there. And what are some of the processes that are in place to have that happen? It speaks to the possibility of best practices and what might those best practices look like. And I think that could be a real valuable resource. Yeah. Awesome.
Yeah, I was going to say, I think that falls within the ability of ISMIC to self-determine to some extent. If the group wants to come up with a little bit more specific recommendations, we've used these as our guide, but when you really look at them now, looking back, given that they're 7 or 8 years old, we've moved on past a lot of them, and a lot of them don't have a lot of specificity. So adding some specificity might be really helpful at this point to move this one along. Okay. So I don't know if we're having a motion, or we're just, discussion is just encouraging the focus group to go back and sort of think of a little bit more specific.
Maybe that's the motion. Do we
Could
have
be
to
a
vote
kind
on
of
it?
Emotion. It codifies it if there's an emotion. If there's
Okay.
an emotion, not emotion.
Okay.
There's that too.
Okay, so why don't we do this? So let's have we'll do a motion for the group to go back and develop additional recommendations that align with some of the discussion that we had. Great. Second? Great. All in favor, say aye.
Aye.
Any nays? All right, great. Thank you so much to that work group. I think that's going to be a really nice addition to the recommendations, so. Okay, so why don't we do that? Yeah. See, thank you. These formalities, this is how you got, it's what? It's good teamwork, right? Teamwork makes the dream work. Okay, so now we're going to go back and we're going to do a motion to approve the report of the work group. So can I have a motion to approve the report of the work group of the criminal justice?
So moved.
Second? All in favor, say aye.
Aye.
Any nays? All right, so the report is approved, and then the work group will add some additional recommendations for our next meeting as well. Great, thank you so much. Okay, and so I think,
So there's a couple of things. We do have a slight break right now that we could lead into before focus group area 1. But I just wanted to bring something to folks' attention for your work for the trauma specific recommendation. I did notice that there is a recommendation about trauma and whole person care, recommendation 3.4 that already exists. Make trauma informed whole person healthcare the expectation in all of our systems of care for people with SMI and SED. So we might want to, so just as you guys are thinking about that, how maybe possibly between working groups 2 and 3, the access and treatment groups, that you guys might want to come together and talk about how these maybe overlap, increase specificity, revise any of them, add something. Just wanted to bring that to folks' attention to think about working together. Yeah. So we have about 10 minutes until our next speaker will be on. So if you guys want to get a quick glass of water or something, and then we can get back in by 2:25 or so, 2:20, 2:25. And then it's Sandy and Nima, you guys can.
Focus Area 1, which is the Data and Evaluation Working Group. We have with us Dr. Sandra Resnick and Dr. Nima Sheth. And so we'll turn the floor over to Nima and Sandra now.
Thanks so much, Dr. Delphmertman. And I apologize to folks. I'm on my phone, so if I'm having some connectivity issues. So if I can't if I can't see something or I can't hear you, just let me know for any given reason. But so happy to be presenting out on the Group 1's report on data and evaluation. Our co-stewards are myself and Dr. Sandra Resnick. We continue to have our federal members present: Peggy O'Brien, Jessica Barber, Kate Beislein, Joel Dubinitz, Jennifer Huinsky, Kirsten Painter, Michael Schoenbaum, Mina Vitalangam, Michelle Leff, and our non-federal members join with a couple of new ones. So Sarah Vinson, who's new, and then Jennifer Higgins. We're really excited to continue to have them and welcome Sarah Vinson. And then our meeting frequency right now is every 2 months. Next slide. So the recommendations for us are these 4 that we had initially put forward. We are currently, I guess the ones that require new activities have been 1.6 and 1.7. 1.1 we continue to work on, and it continues to be a priority, and we have a very good amount of coordination. In fact, we also have a federal only working group on measurement-based care, where we collaborate across various federal agencies around measurement-based care and some of the work that pertains to ISMIC. But we continue to meet with full ISMIC on a regular basis. But in order to continue to further work, we do have a federal work group as well to help with 1.1. 1.6, we have accomplished a lot, and I'll cover that soon. And then 1.7, the last ISIC meeting, we did vote to make this a little bit more focused on MBC. And 1.8 is an activity that we are tracking around current linkages that are occurring. Next slide. So around priority 1.1, some of the triumphs that we've had, like I was saying, we have that federal working group. Also, our group on data and eval brings a team across HHS and the Veterans Administration that have lots of expertise and experience in measurement-based care and a focus on its implementation. Also, the federal working group has other colleagues from, and the ISMIC has also NIH, has other colleagues from across the federal government. And the collaboration is the only interdepartmental federal government effort focused on primarily MBC, and it's allowed us to make a lot of the progress that we're going to report on in 1.6 and 1.7. So next slide. So under 1.6, this is the priority recommendation. So our focus for this priority over the past 2 years has been on measurement-based care with a long-term goal of supporting further integration of measurement-based care and evidence-based clinical processes in community-based settings, providing behavioral health services. Measurement-based care is a best practice that uses data to inform and improve the quality of care and outcomes. And we'll talk through some more of the triumphs around 1.6 in the next slide.
Nima?
Yes.
Before we do that, one of the conversations I had this morning made me think that it might not be such a terrible idea to define measurement-based care, because what we know is that even among people who are familiar with the term, they may understand it differently. So I'm just going to take a second. So measurement-based care, as we talk about it in our group, is a clinical process that uses quantitative data as the foundation for clinical work. It isn't an algorithm. It isn't a performance metric. It isn't about slavishly using data to inform the next thing. What it really is a platform for having transparent, collaborative, shared decision-making discussions, for goal setting, for all the things that we think of when we think about patient-centered care. But
happens to use often a patient-reported outcome measure, a quantitative measure that is the foundation of that work. So we've heard a lot of miscommunications and misunderstandings about what measurement-based care is. So I wanted to make sure that everyone who's attending this meeting today knows that that's what we're talking about. Did I miss anything, Joel? All right, we're good. Thanks.
Thanks so much, Sandy. Yeah, please jump in here any point, and others from our working group as well. If you have points of clarification, I think that's incredibly helpful and important. So sorry about all the words on this slide. We have a lot of accomplishments that we want to highlight. So starting with, this is over, the last 2 years since the beginning of this work for us here. We have a publication, a brief report on the ISMIC website that talks about some of kind of measurement-based care 101. That was a really collaborative effort between members on the working group. And then we had a SAMHSA-sponsored convening on measurement-based care regarding facilitators and barriers to implementing measurement-based care, and a lot of interesting themes that came out of that work around workforce barriers, workflow barriers, models that have worked. We had lots of speakers come talk about how they're implementing measurement-based care in various settings, including hospital settings or child-focused settings, behavioral healthcare settings, or schools, and then also behavioral health clinics. And then we had integration of the recommendations for use of measurement-based care into SAMHSA's updated CCBHC certification criteria. And then some of activities related to research on the financing of measurement-based care, because this also did come up in the convening as a theme around how we can reimburse and fund measurement-based care activities. So within the CFRI, the Center for Financing, Reform and Innovation, in partnership with CFRI, we are developing a report on financing options for measurement-based care in the provision of behavioral health services in community settings. This report draws on both literature and discussions with experts in the field, is expected to be released before the end of the year, and will be accompanied by a webinar with highlights of the report and a panel discussion. And that report is being actually led by Peggy O'Brien, our old co-steward, who is still on our work group and who continues to be a great leader in this work. And also thanks to Joel Dumanitz for providing a lot of input, and Sandy Resnick on this report as well. So we're excited about that report. And then another exciting thing that we want to share is that, SAMHSA has this new center that has been awarded to Stanford. It's just recently been awarded and is currently launching. It's called the National Center for Mental Health Dissemination, Implementation, and Sustainment. And it is a center, it's a technical assistance center that's been established to assist those in the community, but also primarily SAMHSA grants, technical assistance grants, service grants, infrastructure grants, and provide support around process improvement and change management. There's a number of things in the center that the national component of it is creating kind of core resources around, and then there's sub-regional components as well that provide more hands-on technical assistance around some of this process improvement priorities that have been outlined. I won't get into the weeds, but what's important here is that we've asked the National Center and the required activities to develop core products for technical assistance around measurement-based care that includes a national repository of patient-reported outcome measures appropriate for use in measurement-based care that's vetted by experts, and then to provide guidance on the implementation of those PROMs to enhance patient-centered care and improve patient outcomes. So it's really going to be providing some level of, and it could be, and it could be just the resources they create, but they have the capacity to do hands-on implementation support for the measurement-based care resources that they've provided through the what are called MTACs, or the sub-regional components of this center. So really, really excited about that addition, and that should be launching. So we have a technical expert panel as part of this work, and at least one or more persons on the technical expert panel have to represent measurement-based care as the area of expertise. So we're really excited for that work, and we'll continue to report out on the progress that they make. Next slide. So under 1.7, we, which is to identify and work to build on previous efforts to develop a quality measure that measures use of MBC in community-based behavioral health settings. We've also made some progress here. So I think you all recall at the last ISMIC meeting, we received approval to change 1.7 from a broader focus to being more focused on measurement-based care implementation so that we could really double down on our efforts around measurement-based care, and that we could kind of make the efforts that we have in 1.6 continuous with the quality measure work that we would want to do in 1.7. And we've continued to get a better understanding of the lack of general quality measures. We've continued to have conversations with stakeholders such as the APA on why, what the barriers are and, you know, what we could do to kind of further this issue. Next slide. So now we'd like to take some time just to get some feedback from the group, if possible, around these two questions. So one is, if we were developing quality measures focused on the use of measurement-based care and behavioral health, what measures would be most needed or useful? Because this is kind of one of the next stages of our work, is to do a bit more work on 1.7. So we would like to hear from the ISMIC. And then second is any other suggestions from this group as we move forward in our work on measurement-based care. So if anyone has thoughts on either of these questions, we'd love to hear from you all now. You might have to help me with some of the hands, I think. Yeah.
Yeah, there's a question on the screen. So Sean?
Hi, yeah, just want to, I put it in the chat. There's a lot of emphasis in the report on person-centeredness, which is great. And just I added a comment in the chat that you know, NCQA has a measure on directly measuring goals and person-centered goals that people have, and using goal attainment scaling. It's in the muck list right now, the CMS muck list. They've tested it with the people who participate in the community care, sorry, the community-based care or